Hello again. I'm sorry about the mix-up. This is Dr. Wiam, Senior Consultant Endocrinologist from Bahrain. Again, it gives me great pleasure to welcome you all to the Adult Clinical Practice Symposium in Adrenal and Pituitary. Before we start, I'd like to urge you all to visit the exhibition and visit our sponsors booth and abstract room as well. And please remember, if you are not a member of the association, this year we are giving a free membership to all. So try to utilize this free membership. Today, we will cover very important clinical topics, 2 adrenal and 2 pituitary. And we have for you 4 internationally renowned speakers lined up for you from United Arab Emirates, Saudi Arabia, and all the way to Rochester, Minnesota. Finally, it truly gives me a great privilege to co-chair the session with Dr. Hussein Saadi. He is the chair of the Medical Subspecialties Institute of Cleveland Clinic, Abu Dhabi, and he's also a clinical professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and a professor at Khalifa University. I met Dr. Hussein and worked with him almost 26 years ago in Cleveland Clinic during my first fellowship, and it's really nice to have him with us. With that, I'd like to hand over to Dr. Hussein. Abu Fadl.
Thank you, Dr. Wiam, for the kind introduction. It's my pleasure to be co-chairing this great session with him. And we have eminent speakers, of course, Professor William Young, who's currently the Tyson Family Endocrinology Professor of Medicine at Mayo Clinic. He's well known to most of you, having delivered more than 650 lectures, international and national, at more than 150 institutions across the globe. He's well known to everyone, and we are really delighted to have him with us today to talk about a very common topic, glucocorticoid withdrawal tips and tricks. Professor Young, please go ahead.
Thank you, Dr. Saadi, for that kind introduction. Let me just share my screen here. So with regard to this topic, I've come up with an approach over the years with regard to this problem. It's an issue in our patients who have endogenous Cushing syndrome, and we've cured them, and now they need to recover. But more commonly, it's an issue with patients who are placed on glucocorticoids, and eventually it's discovered that they probably don't need them. They probably didn't have that underlying diagnosis that they were initially placed on glucocorticoids for. With regard to this presentation, no relevant financial relationships to disclose, no off-label drug usage. So the outline for my presentation is shown in this slide. I'll review the Mayo Clinic approach to monitoring the recovery of the hypothalamic pituitary adrenal axis after resolution of Cushing syndrome, whether endogenous or exogenous. And along the way, I'll share some tips for success. So this is my 23 rule. So 20 milligrams in 3-week rule. So it's likely that the HPA axis is suppressed if the glucocorticoid dose has been 20 milligrams of prednisone or the equivalent every day for 3 weeks or more. Or the patient's been on a bedtime dose of prednisone, 5 milligrams or equivalent, for more than 3 weeks. HPA axis suppression is possible, and more likely the higher the dose, if the dosage of prednisone is 5 to 20 milligrams a day for more than 3 weeks. And finally, HPA axis is unlikely, but it could still happen if there's any glucocorticoid dose given for less than 3 weeks, or if the patient's on alternate day prednisone that's less than 10 milligrams every other day. So that's the background of what causes iatrogenic suppression of the HPA axis. And I mentioned prednisone or its equivalent. So this is the glucocorticoid equivalency table that we all learned in medical school. You can see prednisone here in the top middle, 5 milligrams is equivalent to 20 of hydrocortisone and is equivalent to 0.75 milligrams dexamethasone. So how should we test the HPA axis recovery after it's been suppressed by endogenous or exogenous corticosteroids? And I have a hint. I personally have not ordered a cosentropin stimulation test for this purpose in more than 2 decades. So we published our approach to this problem a couple years ago now in Clinical Endocrinology. We published this retrospective study of 81 patients with subclinical Cushing's or moderate to severe adrenal dependent Cushing's who developed adrenal insufficiency after unilateral adrenalectomy. The recovery of the hypothalamic pituitary adrenal axis occurred at a median of 4.3 months after adrenalectomy. However, the more severe the Cushing's, the longer it took to recover. So for severe Cushing's, almost a year. For moderate Cushing's, almost 3 months. And for subclinical Cushing's, about 2 months. The main predictors of that recovery interval, how long it took to recovery, included what was the result of the 1 milligram overnight dex suppression test prior to surgery. If the serum cortisol is higher than 10 microgram per DL, it took longer, an average of 9.7 months. Whereas if it was less than 10, it was the average of 1.3 months. Duration of symptoms. If it was more than a year prior to being diagnosed with Cushing's or subclinical Cushing's, then it took almost a year to recover. Whereas if it was less than a year for symptoms, about 3 months. The presence of moon phases, in other words, physical stigmata of Cushing's. If they're present, it took longer. If they were absent, it took shorter. If there was myopathy present, again, it took a little over a year versus about 3 months if no myopathy. None of these should be surprises. It basically reflects the more severe the Cushing's, the longer the Cushing's, the longer it's going to take for the HPA axis to recover. Glucocorticoid withdrawal symptoms were observed in all the groups, whether the patient had severe Cushing's, moderate Cushing's, or subclinical Cushing's. But what proved to be controversial during the peer review process was how we monitored the recovery of the HPA axis. Indeed, it appeared this paper was not going to get published. We had a conversation with the editor and challenged a couple of the main issues brought up by reviewers. One of them was that we didn't follow the Endocrine Society guidelines. And why is that? I'm going to show you our approach to glucocorticoid taper and monitoring the recovery of the axis. So let's say the patient has typical Cushing's and we've cured them with surgery, whether it's pituitary adrenal dependent. Typical dose they go home on a prednisone is 10 and 5. There's 4 times in a day when you give steroids: breakfast, noontime, evening mealtime, bedtime. So that's what that means, 10, 0, 5, 0. 10 in the morning, none at noon, 5 at evening mealtime, none at bedtime. If the patient has ectopic, more severe Cushing's, we may send them home on an even higher dose. Then we drop that dose by 2.5 milligrams every 2 weeks. So it goes 7.5, 5, 5 and 5, 5 and 2.5. Once we get to 5 and 2.5, we substitute a shorter acting glucocorticoid, hydrocortisone, with an equivalent dose, 20 and 10. Then we drop that dose by 5 milligrams every 2 weeks. So 15 and 10, 15 and 5, and then just 15 in the morning, and we keep it there. No more taper. We simply check a morning cortisol before they take their morning dose of hydrocortisone every 6 weeks. When the morning cortisol is above 10, the HPA axis has recovered, we stop hydrocortisone. So that's our approach to monitoring the HPA axis after it's been suppressed with either exogenous or endogenous cortisol. So to get this paper in the literature, we had to make this point that this represented our extensive clinical experience and that we did not follow the Endocrine Society guidelines. The argument we made is everyone always followed all the guidelines. How is we ever going to have innovations? It's really a roadblock to progress. And the third thing we agreed to was to have a commentary published with the article. And here's the commentary. by Seajor and Murray, and it was actually quite positive. Hurtado et al. Have described a clinically sensible approach to the management of potential adrenal insufficiency following unilateral adrenalectomy for autonomous glucocorticoid secretion. This approach is safe and avoids dependence on repeated stimulation tests of the HP axis. Many endocrinologists would, however, find it preferable to confirm a normal HP axis with a stimulated test once recovery of the axis is suggested by the ADM cortisol. So the key message of this article was simply check a morning cortisol before the patient takes their morning dose of hydrocortisone to monitor for recovery. By measuring cortisol from the adrenal, you're determining how well the hypothalamus is making CRH, you're determining how well the pituitary is making ACTH, and you're determining how well the adrenal gland is making cortisol. It's testing the whole axis. Whereas a cosentropin stimulation test is just testing the adrenal glands. And that, to be honest, that's not what I'm worried about. The adrenal will always wake up. I'm worried about the hypothalamus and pituitary. When the morning cortisol is above 10, the axis has recovered. And there's no need, absolutely no need for cosentropin stim tests. So tips for success in this process. It's all about patient education. So we have a patient education guide. It's several pages. You've been taking a high dose of cortisone-like medication. We designed this primarily for exogenous Cushing syndrome because that's actually the most common scenario faced by endocrinologists. Your physician has decided you don't need to take the steroid medication long-term to treat your disorder. And this is information is provided to slowly taper your high dose. And we address several key points in this education guide. One is it's going to take many weeks or months to taper off, and why they can't just stop a glucocorticoid, and why their dose was high to begin with. And finally, at the bottom there, if your dose of medicine is lowered too quickly, you will get very sick. And this is a really important point. Everyone who tapers off steroid meds goes through withdrawal. And this includes having flu-like symptoms, muscle aches, nausea. Going through this stage is common and necessary side effect of tapering your medication. If you feel so bad that you're curled up in bed, you can't go to work or school, your care team will need to slow your taper or change your dosage. Everyone has withdrawal symptoms, but the goal is to reduce your medication slowly enough that you can handle your symptoms and continue your daily activities. I tell patients it's as if their body is addicted to high levels of cortisone-like medications, and like all addictions, there will be withdrawal symptoms. These withdrawal symptoms cannot be avoided if the patient wants to get off steroids. The only way to make them less severe is to slow the taper. But it's up to the patient to decide if he or she wants to go through this process. If they can't handle it, they can't handle it. I tell them fine. Simply stay on a maintenance dose of glucocorticoid for the rest of your life. Many times patients want to load this responsibility back to you, but all we can do is give them the recipe. It's up to the patient to put up with the withdrawal symptoms. So this is a part of this handout we have. We list their steroid and we give them their taper. And again, the 4 times that you can take a glucocorticoid: breakfast, noontime, evening mealtime, bedtime. This is prednisone 10 and 5 for 2 weeks, 7.5 and 5 for 2 weeks, 7.5, 2.5, and finally 5 and 2.5. Once they get to 5 and 2.5, we switch them to equivalent dose for shorter acting glucocorticoid. If you keep them on prednisone, this dose, the hypothalamus is never going to wake up. So we need a shorter acting glucocorticoid, single dose in the morning. That's our goal. If the patient has intolerable glucocorticoid withdrawal symptoms, with this pace of taper, go back to the previous level, slow the pace, and instead of dropping every 2 weeks, you could drop every 3 weeks. Or you could decrease the amount of drop. Instead of 2.5 milligrams, you could drop by 1 milligram. Once they're on hydrocortisone, it's 20 and 10, 15 and 10, 15 and 5, 15 milligrams in the morning thereafter. If the patient wants to and can tolerate a faster taper, and every now and then I'm surprised. I mean, most patients actually, they want to get off steroids and they want to do it quickly. If they can do these drops every week, fantastic. The quicker, the better. And this is where we tell them how to get ready for that blood test. The day before the blood test, just take your morning dose of hydrocortisone. The day of your blood test, have the blood drawn before you take your morning dose of hydrocortisone. If your morning cortisol's normal, above 10 micrograms per DL, I'm sorry, if it's less than that, then we repeat those steps. Where if it's higher than that, we want them to contact us to confirm that, yes, they can stop their hydrocortisone. And this is an important point. Patients get distressed when they're, first of all, their cortisol levels are undetectable, then it goes to 1.6 microgram per DL, then it goes to 3 microgram per DL, then it drops back to 1.9. That's normal, that's typical. It doesn't go up in a straight line. The one caution here is if the patient's taking oral estrogens, that increases cortisol binding globulin, and we need to have a higher cutoff for our cortisol level rather than 10 micrograms per DL. If the patient becomes ill during the taper, they should follow sick day protocol, double their dose of glucocorticoid. If they have recurrent vomiting, they should be treated with IM or IV glucocorticoid and follow sick day protocol. As the endocrinologist, you provide the recipe for how to get off glucocorticoids. It's up to the patient to make it happen. If they can't tolerate the withdrawal symptoms, again, okay, treat with standard glucocorticoid replacement for life. Well, those are some of my tips and tricks in this process. I'll be happy to address any questions you may have during the Q&A section. Thank you very much for your attention.
Thank you, Professor Young, for wonderful presentation. I turn the microphone now to my colleague, Dr. Hussein.
Moving on, our next topic in adrenal is adrenal incidentuloma. The speaker is our friend, Dr. Ahmed Hassoun. He's very well known to all of us. He doesn't need any introduction. He was trained in Rhode Island, Brown University, and then he completed his fellowship in Mayo Clinic, Rochester, Minnesota. And then he became an attending in the Mayo Clinic. And he has actually been practicing for almost 20 years now in the United Arab Emirates. He's a fellow of the American College of Physicians. He's a fellow of the American College of Endocrinology. He's actually the co-founder of the Endocrine Club in the United Arab Emirates for the last 19 years. And it's good to know that Dr. Ahmed Hassoun is the first president. He was elected 9 years ago for this society, which used to be called Untitled Chapter. And he contributed significantly to this association. He actually is the one who founded the Endocrine Board Review that is used and attended by junior and senior endocrinologists in the Gulf area and even the MENA region. He received many awards. One of it is the Ibn Sina Distinguished Service Award. And he authored many papers, more than 50 articles in PubMed index journals. Dr. Ahmed Hassoun will be talking to us about adrenal incidentuloma. The floor is yours, Dr. Ahmed.
Thank you, my friend, Dr. Wiam. And I would like to start by thanking the organizing committee for inviting me to be with you today. But unfortunately, it will be very difficult to follow my mentor, Dr. Bill Young, after his excellent presentation as usual. My presentation is going to be addressing adrenal incidentuloma from a point of some practices that we encounter in our patient in Dubai. I have nothing to disclose. I'll try to give some few points about a background, presenting two cases that I have encountered, ending with some guidance to the approach available in the literature, and leave you with some take-home messages. I'm sure all of you are aware of incidentuloma definition. It's a mass in the adrenal. It's a lesion that is 1 centimeter usually or more. It's found during an examination for other cause of abdominal pain or chest pathology. And we have seen that this has been increasing significantly in the later years because of the advances in technology in CT scanning and MRI, and also the increased use in our clinical practice. And you can see here, the prevalence of this incidentalloma has increased significantly from the time in the late 80s, when it was estimated to be 0.4%. In 2001 publication, it went up to 4.4%. And later in 2017 and 2018 publication, estimated to be around 7.3%. And it's also known that it's more common in elderly, reaching 10%. And also studies of autopsies of people who are normotensive and hypertensive showed that in normotensive people, the autopsy showed 9% adrenal masses incidentalloma and 12% in people who were hypertensive. The incidence is the same, is really increasing significantly. Studies and in the 1995 shown here that the incidence was 4.4 per 100,000 person years, and significantly increased in 2017, tenfold, reaching to 47.8 per 100,000 person year, tenfold increase since then. Now, I'm starting to just present to you my cases that I encountered, and you can see this case here is my first patient. Let me go back here, I think. Okay, here we go. It's an Arabic gentleman during his evaluation for abdominal pain, CT scan done to the abdomen and revealed the presence of 2 by 2 centimeter adrenal mass. And if I just can go back here, and you can see that's the mass highlighted there. And this was a contrast enhanced, so the Hounsfield was high, was 46. That's how they did it. The second case is about a Caucasian gentleman. During his evaluation for his chest, a CT scan of the chest revealed the presence of adrenal mass, which was later confirmed by MRI of the abdomen. And you can see this is the CT scan of the chest, showing the two, actually there are two, the left and the right, but the left is larger. And in the MRI, you can see it here as well. Now, what we need to know when we face such an incidentalloma is to discuss and to know, is it malignant or is it function or both? Is it malignant and is it functioning? These are the two important questions that we need to look at. So going into the malignancy points of the adrenal incidentalloma, it is estimated that the frequency of primary adrenal carcinoma reaching 2 to 5%, depending on the studies, and non-adrenal metastasis in the incidentalloma is lower, 0.7 to 2.5%, although this has been probably increased lately with the advances in managing cancers. The predictors of being malignant is the older age, male gender, larger size, more than 4 centimeters usually, and higher unenhanced CT scan attenuation. A study from our group at Mayo Clinic, led by our friend, Dr. Young, an Olmsted County resident, they looked into the incidentalloma and published that in 2020. 3.3% were malignant only, 88% adenoma, 0.8% pheochromocytoma, and 7.8% were other benign tumors such as myelolipoma, hematoma, and others. If you look at the adenoma, you could see that Cushing syndrome and primary hyperaldo were about 1.1%, followed a higher level of subclinical Cushing syndrome, non-functioning adenoma, and some other adenoma that were apparently not known their hormone status during reviewing them. Now, the question again is it functioning, as we said? So to look into the functioning, I don't want to bother you with Cushing syndrome, but this is one of the clinical features that we see in people with high cortisol level, and you can see it here, and I'm sure most of you are aware of this. And also to look into clinical features of the other hormones secreted by the adrenals, such as catecholamines in the excess. And you can see these are some of the symptoms that we encounter in people, such as the people with pheochromocytoma or aldosterone excess, and that's mainly really being hypertensive or having hypokalemia. Now, in addition to that, so some of these masses and some of these patients don't have the symptoms, they don't have the clinical features, but they might have secretion of these hormones. So it is recommended to check biochemical status of these masses. And as you can see here, hypercortisolism, primary aldo, pheo, and adrenal androgen excess, especially in women. And these are the recommended tests that we are doing. Going back to my first patient, and I'm just highlighting here the history and the physical. And I know you don't have time to read it all, but basically you can trust me, there was no clinical features of Cushing syndrome, and there were no clinical features of catecholamine excess or hyperaldo. He was not hypertensive. And actually, they recommended, as this is published and presented by Dr. Young many times, this is the initial investigation that we need to do in our patients in subclinical Cushing to look into 1 milligram dex suppression, DHEAS. And if CT scan, not in our case, was done unenhanced, and it was more than 10 Hounsfield unit to measure the catecholamines as mentioned here. And if the patient, again, not in our case, if has hypertension or hypokalemia, then we need to check plasma aldosterone and plasma renin. Now, this is my patient, the first case. Potassium was okay, no hypertension, no hyperaldo was evaluated in this case, but we have checked for the cortisol, and you can see some confusing numbers in the ACTH was suppressed here. I was thinking that that was probably done by wrong from the lab itself, whether it's how to take it from to the lab, or it was done in the wrong time. That was before I was involved in the case. Cortisol AM was also on the lower normal range, 7.1. But because of that, and because of the recommendation, we did the catecholamines in this case, because we did not have an unenhanced level. So the enhanced contrast CT was high, and we needed to really exclude pheo or catecholamine excess. And you can see that all the numbers for 24-hour urine studies of the catecholamine and metanephrines were all within normal range. So we did the free cortisol, and again, you can see 24-hour urinary free cortisol. By the way, this is done different time, and you can see that it is higher, more than double than the normal, the upper normal range. But when I reviewed the case, I saw that the urine volume was very high, and I have discussed some similar cases with my mentor and colleague, Dr. Young, and this is very important to correlate with the urine volume. So the urine volume in this case was 5.8 liters, surprisingly. Now, for that reason, we need to be sure that we are not missing, or we need to confirm if he really have hypercortisolism. We did the 1 milligram dex suppression test, and the cortisol was suppressed 1.46 microgram. And also we did salivary cortisol late night, and that was low also. So now the question about this case, is it functioning? We felt it is not functioning. Is it malignant? We need to look into that. This is a very nice table. I think I need you to probably look into the reference of it. It is in the endocrine practice by GAED, and it was presented in one of the conferences as well, published in 2019. You can see there's characteristics of the imaging of adrenal masses that make you feel it is more likely to be benign or suspicious for malignancy. And I'm going to highlight for you something relevant to our cases today. The size, if it is less than 4, is likely to be benign. And density on non-contrast, which we did not have in the first case, and even probably the other case, it is less than 10, it is benign. And if it is more, it is likely to be malignant. But we have contrast washout on CT protocol 10 to 15 minutes in the case, and it should be, if it's benign, absolute reduction 60% or more. And also we have MRI chemical shift done on the study, and if it is a positive shift, then it is actually more with the likely to be benign. This is a paper that was presented many years ago and published in 2003, just showing the same principle of the contrast enhanced. As you can see, lipid rich, lipid poor, non-adenomas, and including pheo and probably also the cancers here. You can see that unenhanced is very low in people with lipid rich, which we mean adenoma here. And even in the lipid poor, it is a little bit higher. But if you go to the second part here, you can see the true percentage washout is again, in both cases, whether it is lipid-rich or lipid-poor adenoma, they will significantly reduce more than 60% in both. Unlike in the one that is, you can see, non-adenomatous and including for example, the cancers here. This is our patient. This is again done and looked into that and reviewed with the radiologist. And you can see here that the mass here, as we mentioned earlier, the Hounsfield was 46. It's a coronal view. And the one delayed image shown here to show the washout, it was 46 went to 16, and the 65% was the washout. Again, in a different view here, looking into, again, the same washout time, and you can see it's, again, almost the same number, 65% reduction after the delayed image. This is another paper published, an important one in American College of Radiology in 2017, looking into the adrenal CT washout significant, looking into our case here, the absolute washout 60% or more, signify benign adenoma, and actually in these cases it's recommended, they are non-functional and recommended to be no follow-up. Our case, the first case again, went into an MRI study. They were doing more MRI rather than CT in my new place. And look at this one here, you can see that the mass measurement in the MRI in phase, but the important part again here is the chemical shift, or what we call MRI out of phase. There was loss of signal, as you can see here, signifying more of a benign nature of this mass. So now with this, we could say it looks like non-functioning. It is less likely radiologically, malignant. And going to our friend and mentor, Dr. Young, this is one of the algorithms. I have modified maybe the colors or something in it, minor. I know he will forgive me if I did something different a little bit, but you can see here, looking at the imaging phenotype on our first case. Now, the question is, if you have these two, but what we have in our case, we have these things. CT contrast washout more than 60%. MRI chemical shift was there. Size less than 4. Most of it looks into a benign nature. Unfortunately, the patient underwent and decided to go for surgery after counseling with the surgeon. And the surgeon were discussing with the patient about some of the features that really not significant, but the patient was leaned more for doing the surgery. And this is what happened as the pathology of the surgery turned to be benign non-functional adenoma. And the course went very well, smooth, without any complication, peri or post surgically. The second case, again, I don't want you to bother on this. I just highlighted in red for you some of the important points here. Family history, there is hypertension. There is question of adrenal adenoma. We're not sure of it. And the patient was not clear about it. Past history of the patient himself has type 2 diabetes and hypertension as well. So if you look at the features of Cushing syndrome, nothing except being diabetic and having hypertension, which are significant. And with regard to catecholamine or hyperaldo, again, he has hypertension in that regard. So the patient underwent evaluation before coming to see us. And that was actually, this is done in our center before. And that's, you can see that this was showing all of them are benign. So it's a non-functioning again. And just to look into the picture, this is the CT scan of the chest showing the mass. And this is again in an MRI done. And this is the measurement in 2017, the first time seen. And according to that outside record, actually this is an outside record, showing that the measurement is, in the right is 17 millimeter in the highest diameter and 37 on the left side. And the question or the diagnosis was mentioned that it looks like more of a benign adrenal myelolipoma. This was given to us later on after we asked him to bring it. But while he was with us in the clinic, he asked us to be sure that of the diagnosis, and he underwent further evaluation. As I told you, the functionality was done. It was normal, non-functioning. And this is an MRI done soon in 2018 as a follow-up. I think it's about 7 months or 8 months from the first study done outside. And again, the message from here is again, the MRI chemical shift was done. We did not have at that center before CT scan. They were depending much more on the MRI investigation. And we can see that it signifies for benign nature of these two masses. Now, looking into this and looking into the same paper of the radiology, you can see that the diagnostic benign imaging features, if you have that, different than if you have intermediate or worse. And these are the people who are recommended, for example, if it was myelolipoma, no enhancement, then you have to think it is really benign and no follow-up is needed. Again, if somebody is less than 10 Hounsfield unit, again, benign nature. And mentioned here also the masses with diagnosis of benign nature, including the myelolipoma, as we know, cyst, hemorrhage, and other masses mentioned here. So I will just move to the guidance approaches that my colleague and mentor, Professor Young, who have always taught us how to go with this. And you can see here, without going into the details of it, that you start with initiating of hormonal evaluation secretion, as we mentioned earlier. But if it is secreting and functional, then you need to confirm it and consider surgery if it is positive. If you could not confirm it, then you go again looking into the imaging phenotype based on the initial imaging. Again, looking at the CT scan, Bill Young and all of us, I think, are depending much more on CT scan protocols. And at Mayo Clinic, I'm not sure if Bill has some update on this. Unenhanced CT attenuation, contrast washout, all benign. If it is yes, again, you go for repeat imaging and follow-up, and maybe periodically every year you do some testing on these cases, and surgery if it is large. Now, if it is not, then you go to have a consideration of biopsy, depending if the patient have history of metastasis or infection, and surgery if physically fit, and basically follow-up, close follow-up, if not, have the surgery at that time. This is from the paper I mentioned to you by Vaidya in the endocrine practice, published in 2019, and summarizing here, in a way, somewhat similar approach with some differences, minor differences here, again, to biochemical evaluation, radiographical characteristic here again. The main thing here, if I just can move this here, is the surveillance. And this is something new that are recommended. So if there is no high-grade evidence for surgery, surveillance consideration, and divided into two types. If initially non-functional, these masses, and no high-grade evidence to support repeated biochemical testing. Consider repeating biochemical testing if worsening comorbidities suspicious for cortisol or aldosterone. At that time you do. And if autonomous cortisol secretion, but without clinical syndrome, individualized consideration for surgery based on the comorbidities and other factors. Consider longitudinal biochemical surveillance, and no high-grade evidence to support longitudinal radiographic surveillance. Okay. So I will end with giving you some take-home messages from what we have learned and from what is in the literature. We know now that the prevalence is really increasing more with the technology we have, including the prevalence and the incidence. And majority of these adrenal incidentalomas are found to be benign. Majority of adrenal incidentalomas are non-functioning cortical adenoma. Imaging characteristics is very important. All the recommendations are to look into the imaging. And this is something important I find that we need to discuss with our radiologists, and to find the protocols that are suitable for our patients. Are essential to look into the characteristics of the images to guide the approach in management, as we have seen earlier. Always exclude pheochromocytoma if unenhanced CT Hounsfield more than 10. Evaluate for hyperaldo only if patient has hypertension or hypokalemia. Now we're talking about this adrenal incidentaloma. And last but not least, longitudinal biochemical and radiographic surveillance should be individualized depending on case by case. And with that, I would like to stop here, and thank you very much for listening.
Dr. Ahmed, that was very nice and brilliant talk. Thank you very much. I have to say that the Cleveland Clinic team here is very happy from the Mayo Clinic team. they are sticking by time, and actually we are very early, so that will give us more time for the questions and answers. I'll hand over now to my co-chair, Dr. Hussein, for the next speaker.
Thank you, Dr. Wiam. It's my pleasure to introduce our next speaker, Dr. Musa Al-Maliki, who is currently a consultant endocrinologist at King Fahd Medical City. Dr. Al-Maliki finished his residency training in Saudi Arabia and then went to the University of British Columbia, where he completed a fellowship in endocrinology, followed by 1 year of fellowship in pituitary disorders. And he went back to Saudi Arabia, where he is currently practicing. He is well known in the field and has published tremendously. Please welcome Dr. Musa Al-Maliki, who will be talking to us about diabetes insipidus. Dr. Al-Maliki.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. It is my pleasure to be here with you this evening. First of all, thanks for that kind introduction, and I would like to thank the scientific committee for having me to speak about diabetes insipidus. I have nothing to disclose. This is the outline of my talk: how to make a diagnosis of DI, know the limitations of classic test of DI, understand the background of cobiptin as new diagnostic tool of DI, know the management of patients with different forms of DI, discuss the post-operative DI, how to approach a patient with adipsic DI, and finally, we'll review the association of COVID-19 and DI. DI belongs to a spectrum of polyuria polydipsia syndrome, which is a group of hereditary or acquired disorder, which is characterized by polyuria of more than 50 ml per kilogram per 24 hours that's accompanied by polydipsia. And as you can see here, it is a result of three basic defects. In central DI, there is decrease in secretion of antidiuretic hormone, while nephrogenic diabetes insipidus, there is renal resistance to the action of antidiuretic hormone. While primary polydipsia, this is excessive and prolonged water intake for prolonged periods of time, which lead to physiological suppression of antidiuretic hormone. So there are several other conditions can present with polyuria. It should be ruled out before labeling a patient with DI. As you can see here, at the top of the list, hyperglycemia and solid diuresis, which can be easily differentiated from DI by the simultaneous measurement of serum and plasma osmolality. Of course, certain medication like diuretic or use of SGLT2 inhibitors in diabetic patient can present with significant polyuria. In acute setting and post-operative time, acute drop of growth hormone after successful pituitary surgery for growth hormone secreting pituitary adenoma can present with polyuria. Central DI, this represents the most common form, which can be due to the either complete or partial deficiency of antidiuretic hormone, can occur at any age in both sexes. This can be a result of either inherited or acquired condition. Among the acquired condition, hypothalamic lesion, which account for up to 40 to 50% of the cases, like tumor, sarcoidosis, trauma, or subarachnoid hemorrhage. DI in the context of pituitary adenoma is not that common before surgery. However, if it is present, we should this should raise suspicion of other diagnoses like craniopharyngioma. Idiopathic, this is diagnosis by exclusion, but has been reported in 20 to 50% of the cases. And the autoimmune process have been described in a subset of patients who was initially diagnosed to have idiopathic DI. Genetic represent in about less than 5% of the cases. Nephrogenic DI, this is a result from the renal resistance to the action of antidiuretic hormone. It is less severe and less common than central DI. This might be due to acquired or inherited condition. In children, it is almost always due to inherited condition. While in adult age group, this result from the acquired condition most of the time. And the most common acquired causes include electrolyte disorder like hypokalemia, hypercalcemia, or hypercalciuria. Also, medication is frequently associated with nephrogenic DI. Lithium is at the top of the list of medication, which involves in about 10 to 20% of the cases. especially in patients with long-term use of lithium. Primary polydipsia is a result from excessive and prolonged water intake. So there is no defect in the antidiuretic hormone secretion or action. And this, it could be dipsogenic if there is a defect in thirst mechanism. And it can be psychogenic in the context of psychiatric disorder. So how to evaluate patients suspected to have DI? The first step is to differentiate polyuria from the most common complaint, which is frequency. Once you are in doubt, 24-hour urine collection, it can be helpful. So once polyuria is confirmed, the second step is to measure urine osmolality and specific gravity. So once hypotonic polyuria is confirmed, the third step is to differentiate the type of DI. However, the clinical picture is not always black or white, as there is some overlap in between. And finally, evaluation for the underlying cause. So to differentiate which type of DI, and water deprivation test or indirect test is water deprivation test, which is the most widely used, can be done as outpatient, where we start the fluid restriction overnight, so the dehydration occur while patient sleeping, and with measurement of morning serum sodium and urine osmolality. Urine osmolality more than 800 or more than 600 exclude DI. However, in patient with severe disease, it should be done in inpatient setting and under supervision. The test should be suspended if there is 5% or more reduction of weight from baseline, or urine osmolality plateau for 2 to 3 consecutive reading, or sodium or serum sodium exceed 145 millimole per liter. Here we demonstrate Dysmorphism and evaluate urine osmolality and volume Q30 minutes for 2 hours. How to interpret the result? As you can see here, this is as per diagnostic criteria that proposed by Miller in 1970. A normal subject, usually urine osmolality more than 800 with no further increase after administration of Dysmorphism. In patient with complete DI, usually urine osmolality less than 300. But if you give Dysmorphism and you found increment of urine osmolality more than 50%, this is going with the complete central DI. If it is less than 50%, this is going with the nephrogenic DI. However, in patient with partial central DI or primary polydipsia, urine osmolality usually between 300 and 800. Here we give Dysmorphism again. If increment more than 9%, this is suggestive partial central DI. If it is less than 9%, this indicates primary polydipsia. However, water deprivation test is widely used and considered the gold standard, but it is suffer from several limitations, including it is not convenient, exhausting for patient, and needs supervision, especially in severe DI. There is overlap in test results in patients with primary polydipsia and partial form. Also, diagnostic accuracy only reported in 70% of the cases, and in patients with primary polydipsia only in 41% of the cases. In addition to that, the sensitivity and specificity for different cutoff and differential diagnosis of different form of DI have not been defined. Measurement of AVP as a direct test, as the AVP, it plays an important role in the water regulation and osmoregulatory function. It has been suggested as an alternative to the water deprivation test to overcome all limitations associated with that test, and with hoping to provide a convenient and rapid diagnostic measure. So the result usually compared with the area of normality in the normogram. If it is lie within the shaded area, this is suggestive primary polydipsia. If it is above the shaded area, this is indicate nephrogenic DI. If it is below, this is going with the central DI. However, it doesn't enter routine clinical practice because it has several limitations. First of all, it is difficult to measure because it has a complex pre-analytical requirement. It has short half-life from 10 to 30 minutes, Also, it's bind to platelet in up to 90%, so it might overestimate or underestimate the result. And finally, the sample is stable for 24 to 48 hours at 4 degrees centigrade. And the turnaround time for the result up to 7 to 10 days. So this might affect the stability of the result. Due to all previous limitation, the cobeptin, it has been suggested as the alternative, and the cobeptin is a peptide that derived from the same precursor of vasopressin. The main function is largely unknown, but it has been proposed as the stable surrogate marker for the endogenous vasopressin concentration. The cobeptin has been evaluated in several studies and found to be strongly associated with the vasopressin at wide range of plasma osmolality. In addition to this, it has several advantages. We need a small amount of blood, around 50 microliter, as compared to 1 ml for the vasopressin. It's stable at room temperature for up to 7 days and can extend up to 14 days at 4 degrees centigrade, and we can get the result within a short period of time, up to 2 hours and a half. This algorithm summarizes the use of cobeptin for differential diagnosis of different forms of DI. At the baseline, without prior testing, if it is more than 21.4, this is indicate nephrogenic DI with high sensitivity and specificity. If it is less than 2.6, this is indicate central complete DI. If it is in between, we have to do water stimulation, water deprivation test, or we give hypertonic saline stimulation to ensure sodium more than 147 millimole per liter. If the stimulated cobeptin less than 4.9, this is suggestive partial central DI. If it is more than 4.9, this indicate primary polydipsia. MRI, this emerged as another diagnostic tool in addition to biochemical testing, and with focus mainly on the infundibulum and posterior bright spot, although both of them non-sensitive or specific. Bright spot, it can be absent in 20% of healthy subject, and can present also in 30% of patients with documented central DI, especially at the first stage. But it's very helpful, especially when you are evaluating for the underlying cause. Therapeutic trial of Dysmorphism, it can be done in case of there is still uncertainty about diagnosis, or if you work in a situation where there is limited resources. So we give 10 mic of Dysmorphism intranasally, 2 times daily for 2 to 3 days, and look for the response. If there is significant reduction, if urine output, nephrogenic DI is excluded. If there is significant reduction of urine output and water intake with no hyponatremia, this indicates central DI. In case of there is significant reduction of urine output without a change in water intake and with development of hyponatremia, this is most likely going with the primary polydipsia. Now we'll move to treatment, and treatment should be according to the type and according to the cause. The aim of treatment is to improve patient quality of life and to maintain water and electrolyte balance. In case of central DI, treatment mainly Dysmorphism, which is synthetic analog of antiderivative hormone, and most of the time it is lifelong, except after pituitary surgery, where the treatment is where most of the time it's transient and there is no need for fixed treatment. This table summarizes the dosing and formulation of Dysmorphism, and all of them effective and can reduce urine output within 1 to 2 hours, and the duration of action from 6 to 18 hours. Usually start with the night dose to control nocturia, then adjust according to the response on a weekly basis till we reach the stable dose. Treatment of nephrogenic DI, here might be slightly complex as compared to central DI, with focus mainly on the underlying disorder, if possible, like hypokalemia or hypercalcemia, or discontinuation of the offending medication, if possible. Dysmorphism, it can help, especially in patients with partial nephrogenic DI, but they usually require higher dose. But the most important aspect of treatment here is diet, which should minimize the osmotically active substance, this in form of low protein and low salt diet. Thiazide diuretic, it's another important key in management of nephrogenic DI. which lead to decreased urine output and increase urine osmolality. Amiloride, it can be added to thiazide diuretic to enhance its efficacy and to minimize hypokalemia as a side effect of thiazide diuretic. Also, it can be used in case of the lithium-induced DI. Primary polydipsia, there is no effective medical treatment for this condition, and the mainstay treatment is behavioral therapy to decrease voluntary water intake. Supportive measure, of course, is very important, like the avoiding any medication that can cause mouth dryness, eating well-balanced diet, and the maybe daily weight to assess for the water of being retained, and patient education about the disease and about hyponatremia. Now we'll move to the post-op DI. This is a common condition which occurs in about 46% of the cases, and most of the time it is transient. However, 2 to 10% of the cases can be permanent. Some patients, they are at risk of post-op as compared to other, and this has been explored in several studies, and they found patients with functioning pituitary tumor like Cushing disease at risk of DI as compared to other type of tumor. Patients who underwent extensive intraoperative manipulation of posterior pituitary at more risk. Similarly, the intraoperative CSF leak more likely to be associated with the DI as well. Post-op DI can take several forms. It can be transient with one phase. It can be permanent if there is more than 85% destruction of magnocellular neuron of the hypothalamus. It can be triphasic response, or it can be biphasic response. And the initial diagnosis required to have hypotonic polyuria, which is defined to have urine output more than 300 ml per hour for 3 consecutive hours, and urine specific gravity less than 1.005, in addition to at least one of the 3 relative criteria: excessive thirst, serum osmolality more than 300, or serum sodium more than 145. What about cobiptin? We all know that the cobiptin role is well established in patients with persistent DI, but in post-operative is still not validated yet and require further study. This diagram summarizes the initial diagnosis and treatment of post-op DI, and the most important aspect of management of this condition that we need the shared care between endocrinologist and neurosurgeon, and the also patient should allow to have access to water and should be kept under close monitoring. In case of the documented DI, the patient should be given Dysmorphism MBRN basis and assess the response. In case of persistent DI, we have to give another dose as needed. At the same time, we have to evaluate for sign of resolution of transient DI and for the triphasic response. If the fluid balance positive more than 2 liters, here we have to suspect the second phase or an appropriate antidiuresis. So we have to start fluid restriction and to suspend Dysmorphism. Adipsic DI, this is another challenging and rare endocrine condition, occur mainly in patients with the higher lesion above the median eminence, like patient with a large craniopharyngioma, or patient underwent surgery for the anterior communicating artery aneurysm. This patient, they have DI in addition to the impaired thirst mechanism. So they are at risk of the sodium dysregulation. So they can fluctuate between hypernatremia and hyponatremia. In addition to that, they are at risk of the hypothalamic-related complication like obesity, sleep apnea, and seizures. So how to manage this patient? The principle of management as outlined by Ball in 1997, the most important step is to set a target weight when the patient known to be eupholemic and normonatremic. Patient should be given a Dysmorphism and fixed dose to ensure adequate antidiuresis. Also, we have to determine the obligate fluid intake, the amount of fluid he needed on daily basis from 1.5 to 2 liters, depending on the patient health condition and weather. And also we have to do daily weight measurement to detect any change in the weight. For example, if you detect around, for example, 1 kilogram from the baseline. So 1 kilogram, this will be equal to 1 liter. This should be added to the obligate fluid intake. Also, we have to keep eye on the serum sodium, and another important aspect of management, patient and family education about importance of the water balance and management. The last aspect of the last section of my presentation, post-COVID-19 and DI. DI has been described in literature in patients with the COVID-19, and the central DI believed to be due to the either direct or immune-mediated neurohypophysitis, or due to the hypoxic encephalopathy, especially in patients with the severe respiratory failure. On the other hand, nephrogenic DI has been described as well as consequences of sedation in patient in ICU setting who underwent intubation. The management is the same principle of management of patients with DI. You have to ensure adequate fluid replacement, supplement of Dysmorphism, and with the close monitoring of the fluid balance and with the electrolyte monitoring. What about patient with pre-existing DI? The patient with the existing DI at risk of the complication of the serum sodium abnormalities. Hyponatremia most commonly reported, and most of the times delusional as a result of the chronic Dysmorphism, and majority of patient is mild. However, severe hyponatremia of the sodium less than 130 has been reported in 15% of the cases. And this can be prevented by regular check of serum sodium. Also, patient advised to do the periodic withhold of Dysmorphism administration to give a period of free water clearance. On the other hand, hypernatremia is less common, but it has been reported, especially in patients with severe COVID who admitted to intensive care unit. And this might be due to the insensible water loss or inadequate water intake, or it might be due to the decreased absorption of the intranasal Dysmorphism. Hypernatremia also found to be developed rapidly in DI patient with severe COVID. So how to manage patient with DI or develop COVID? The principle of management has been highlighted in the last clinical practice guideline published in the European Endocrine Society. And as you can see here, in the outpatient setting, the advice to give priority to avoid hyponatremia, and this is emphasized the importance of the delaying the Dysmorphism dose. While in inpatient setting, if patient have mild COVID, the advice to switch from the nasal to oral Dysmorphism and to ensure adequate fluid intake. While in patient with severe COVID, they are advised to give IV Dysmorphism and to give adequate amount of fluid. It should be given intravenously as well, and to give routine prophylactic low molecular weight heparin during the episode of hypernatremia, because hypernatremia is well known as a hypercoagulable state. In addition to the pulmonary embolism is another emerging condition in the COVID-19. And as the majority of patients with central post-op or post-traumatic DI, they have the ACTH deficiency, the advice to give a stress dose of steroid. So in summary, DI is a rare condition, but should be evaluated in any patient with documented hypotonic polyuria to avoid the complication and to maintain fluid and electrolyte balance. The role of cobeptin is well established in differential diagnosis of different forms of DI, but it's still not well validated in patient in post-operative DI. Treatment of post-op DI should be individualized, and this depends on the duration and severity of disease. Management of adipsic DI is a complex and require training and collaboration of patient and their relative. Body weight can be served as a surrogate marker for adequate water and sodium balance. Patient with central DI and COVID should learn how to avoid delusional hyponatremia. Hyponatremia seems to be a common in COVID-19 and intensive care setting and potentially associated with poor outcome. With this, I would conclude my presentation, and I would be happy to answer any question. Thank you.
Thank you very much. It was very informative and very outstanding talk. Now we move to our fourth speaker for today, The topic is growth hormone deficiency in adults, a very important topic. Dr. Salim Bishaya is the speaker. He's well known to all of us. He's a colleague and a friend. He's a consultant endocrinologist in a private practice, Mediclinic Airport Road in Abu Dhabi. He's also a professor at the Dubai Medical College. He has an extensive training after graduating from Tripoli, from medical school in the UK, and wind up doing at the end 4 years of clinical research at St. Mary's Hospital, Medical School, and Imperial College of London, where he did his PhD, and it was concerning the hypopituitarism and growth hormone deficiency. He had 23 years of experience as a senior physician and have a special interest in cultural aspects of medicine, education, and culturally relevant clinical research. He had more than 80 papers published in the PubMed Index and much more than that in other journals. He's also the previous editor-in-chief for Ibn Sina Journal of Medicine and Biochemical Science. And for the last year, he's been the editor-in-chief for our journal, the Diabetes and Endocrine Practice for the Association. One thing important is Dr. Salim is one of the founding board members of this association 9 years ago, and he was actually the past president of the American Association of Clinical Endocrinologists, the Gulf chapter. We are very pleased to have you, Dr. Salim. The floor is yours.
Thank you very much. Assalamu alaikum wa rahmatullah. Thank you very much for that very kind introduction. It is my pleasure to talk tonight in this conference. And the subject is on growth hormone deficiency in adults, or exactly in its deficiency and the benefit of its replacement. I have no conflicts of interest in relationship to this presentation, other than I spent 4 years doing research on growth hormone deficiency in adults. I thought to divide these educational objectives of the session into 3 items: to review first the clinical and metabolic impact of growth hormone deficiency in adults, discuss the benefits and the side effects of growth hormone replacement therapy in adults, and also highlight the guidelines and touch on some of the practical points for the replacement in adult persons. Now, to start with, it may sound like contradiction of terms when you talk about growth hormone in adults, because adults do not grow. However, this is the original name, and the fact that it was restricted to children many years ago is based on the restrictions of availability of the pituitary cadaveric growth hormone till it became biosynthetically available. And that's why when we rediscovered a new condition called growth hormone deficiency in adults, or growth hormone deficiency syndrome in adults. The estimated epidemiology, we talk about etiology of adult growth hormone deficiency as 2 groups of patients. Those who come to us from our pediatric colleagues, the childhood onset, these are a result of structural lesions or traumatic brain injury, but also they could be related to congenital or genetic basis. And also there are some idiopathic conditions. Whereas in the adult practice, for those particularly who are running neuroendocrine clinics, they will actually come across adult onset patients with either acquired or idiopathic conditions. The estimated number of adult growth hormone deficiency is about 1 in 20,000 to 1 in 25,000 per population. The acquired causes of adult growth hormone deficiency of adult onset type is mainly related to pituitary or parapituitary lesions and their treatment, that being surgery or radiotherapy. However, more recently, it has been suggested that brain injury, including trauma such as sport trauma, blast injuries, subarachnoid hemorrhage, strokes, etc., these may actually outnumber the pituitary adenomas in causing adult growth hormone deficiency, and there are data to suggest that in senior or old or retired sports people. There are, of course, a long list of other causes of adult growth hormone deficiency. The point that I would mention, perhaps we still have, even in our age, we can still see more than what we need to see of patients with Sheehan syndrome, which is on the bottom of the list of this one here. So what are the clinical consequences of having a deficiency of a hormone that's called growth hormone in an adult person? And instead of showing so many data slides, I actually used this summary slide here to show the 4 points where adult growth hormone deficiency affects the individuals with this deficiency. Number one is the abnormalities of body composition, which has been shown using several methods: increased body fat, decreased lean body mass, reduced bone mineral density. This has been shown with DEXA, it has been shown with total body potassium, bioelectrical impedance, etc. All methods of body composition analysis confirmed the same. The second one was the increased cardiovascular risk. To start with, there was the Swedish data that suggested from epidemiological analysis that there increased mortality in comparison with non-hypopituitary patients or non-growth hormone deficiency patients. But further analysis also illustrated specifically that there is an increased numbers of strokes and cardiac events. We at St. Mary's, what we've done, we looked at asymptomatic patients, patients who do not have evidence of cardiovascular disease, and we looked at their cardiac function structure, and we looked at their intima media thickness. And we actually published that in the early 90s, showing that even in asymptomatic patients, there is evidence of abnormalities. Also, as a preparation to treat these patients with the growth hormone, we actually measured their lipids and done oral glucose tolerance test on them. And to our surprise, we found that the lipid profiles are disadvantageous, and also to the contrary to what we expected, there is actually increased frequency of glucose intolerance. Impaired quality of life has been illustrated using several methods, several quality of life measures. And the current one, which is the standard method, is the adult growth hormone deficiency instrument that's actually available in English and in many languages. And we have been attempting to make a formal one in Arabic, but the work is not being complete. The impaired physical well-being, decreased exercise capacity has been shown, and reduced muscle mass and strength has been shown by several workers from Europe and North America. So how will we make a diagnosis of growth hormone deficiency in adults? It's similar to any other condition. You have to firstly put the clinical context by the clinical findings, full medical history, and then think whether there is a need to do growth hormone stimulation test or not. What we think, there are groups who do not need any growth hormone stimulation testing, and there are groups who need stimulation testing. But I will show just a single slide where growth hormone testing is not needed. In patients with childhood growth hormone deficiency who are known to have conditions that will not go away by time, such as genetic mutations, bureaucratic lesions, or irreversible structural lesions or damage. Also, patients who are adult onset of growth hormone deficiency who have several pituitary hormone deficiency. We have illustrated that using IGF-1 and the number of hormones. Also, the group from Kiel also is shown the same. So it is now the more number of pituitary hormones are lost, the less likely that actually you need to test, and it is more, and within the clinical context, more acceptable to make a diagnosis of growth hormone deficiency. What are the tests? Similar to what our colleagues in children care practice use. The standard one, the insulin tolerance test, but also growth hormone releasing hormone and arginine test can be used. Glucagon stimulation testing can be used, and also ghrelin test can be used. For most of the trials, they actually ask for 2 tests. The difference between the children and adults for this in this context is that the peak growth hormone response required to make a diagnosis in adults is limited to the severe adult growth hormone deficiency, which is a maximum response of less than 3 micrograms per liter. Although there are some variations. The reason why only severe adult growth hormone deficiency is included in the diagnosis that the benefit has been shown only in those with severe growth hormone deficiency in adults. So what are the demonstrated benefits for growth hormone treatment? These are the first 2 papers published in 1989, the first one in the Lancet and the second one in the New England Journal of Medicine. The first one is from Aarhus, the Danish group. The first author is Jens Jorgensen, who actually came and spoke in our conference a couple of years ago, and that was led by the late Jens Christensen. The second group by the research workers were Franco Solomon from Switzerland and Ross Junior, originally from New Zealand or Australia. And it was led by Peter Songson, who actually happened to examine my PhD a few years later. So just in summary, so that just in case we run short of time, the benefit is mirror image or opposite mirror image for what is being shown as deficiency. Body composition, reduction in fat mass, increase in lean body mass, increase muscle strength. Bone metabolism, increase bone mineral density, but that you'd need at least 12 months of treatment to show that. That continue to be persistent, the benefit is persistent over several years. The cardiovascular risk, all the classical risk profiles has improved, and also reduction in the diastolic blood pressure. Health-related quality of life has been shown using several questionnaire methods, and also some interview methods. Mortality would probably has been shown to will probably be reduced because of the correction of all of these factors. This body composition effects would have been the most consistent in all the trials. So reduction in body fat, reduction in truncal fat and visceral fat, increase in the lean body mass, muscle strength, and exercise capacity. Bone metabolism, as I mentioned, actually bone density has increased, and there was a progressive gain in bone mineral content over 33 to 45 months. The cardiovascular risk, as you expect, all the classical risk factors and move into the right direction, including total cholesterol, LDL, blood pressure, C-reactive protein, and arterial structure has been shown. Both intermediate thickness that we shown originally that is increased in our cohort. Growth hormone therapy also may protect against myocardial infarction, and these data from a retrospective study shown the increased rate of MIs in untreated patients and decreased rate in the treated group. Later data also showed there is an increase in the stroke events, particularly in women ×3 and in men ×2. And after initial treatment, the stroke incidence declines in both sexes. This is just one example of health-related quality of life improvement. As you can see, both in the group as a whole and in adult onset and childhood onset, there is improvement. Of course, there is a lot of factors that influence this, but I think at least the direction is in the right way. When we treat patients, we have to be careful about few things. These are normally transient, such as edema, carpal tunnel syndrome, musculoskeletal aches and pains, mainly because of fluid retention. The serious concerns were about the risk of malignancy and the insulin sensitivity, and I will discuss this in more detail. Malignancy, we can consider it under 3 groups. Patients who have never had cancer, there's no evidence to suggest that the doses you use in growth hormone replacement will actually increase the de novo cancer. Patients in complete remission from a tumor or malignant disease, again, there's no association. And patients who are survivors of childhood cancer, there's slight increase in secondary neoplasms. The enzyme sensitivity, we know growth hormone per se is actually an antagonist of insulin, and therefore depends on the benefit you get from the body composition. To start with, there is a transient decrease in insulin sensitivity, but in the long term, there is 1 year, for example, of growth hormone replacement is relatively safe. And in some studies, there is an improvement in insulin sensitivity. In patients with diabetes mellitus, then we have all the methods how to adjust the doses as required. There are several guidelines. The latest comes from the ACE and the ACE 2019, but as you can see, actually, because of the controversial issue, there's so many guidelines before. But I think the most comprehensive, detailed guidelines are in the 2019 document. These are the doses. In young men, you can start 0.2 milligrams per day. In young women, 0.3 milligrams. And in older people, you get half of the dose. The dosing, you should consider sex, should consider the estrogen status and age, and the doses can be titrated according to the clinical response, the side effects, and the serum IGF-1 level. The standard monitoring should be done at 1 to 2 months and include the serum IGF-1, which should be maintained below the upper limit of the normal range when titrating the doses. Biochemical tests for safety and pituitary gland in patients who have disease in the past. Of course, patients should be interviewed as usual for any adverse events, and the dose should be adjusted. So I think to conclude, Mr. Chairman, adult growth hormone deficiency is now defined as a condition with distinct clinical and diagnostic features. The features are different in childhood onset and adult onset patients. A proper transition of pediatric children should allow a careful assessment of the needs of these patients, whether they need to continue on the treatment or they had their share and there's no need to continue. The diagnosis, as usual in clinical practice, is based on the context, clinical context, and selection of standard biochemical investigations. The benefits of growth hormone replacement therapy include improvement in body composition consistently, bone metabolism, albeit at a later stage, the correctly used health-related quality of life, and cardiovascular risk and mortality. Growth hormone replacement therapy is generally safe, and signs of overdose are either transient or manageable. Thank you very much.
Thank you so much, Salim. That was a brilliant talk. We really appreciate it. This is a very tough topic, and I have to say this is an undertreated and underdiagnosed in this part of the world. I'd like all the panelists to join us, Dr. William Young, Dr. Musa Al-Maliki, Dr. Ahmed Hassoun, and ask the audience to start sending more questions. I'll hand over now the question and answer session to Dr. Hussein Saadi.
Thank you, Dr. Wiam. We have so many questions, especially for Professor Young. Professor Young, in the era of COVID-19 infection, these attendees are asking, steroids are used now liberally, dexamethasone for 10 days, methylprednisolone and others. Do these pose a risk on, HP axis suppression?
Yes, that's a good question. So remember that 20 milligram 3-week rule. No matter what the dose of glucocorticoid, if it's less than 3 weeks, the HP axis will recover basically immediately. So it's not an issue. So for most of the COVID patients, they're going to be on dexamethasone for less than 3 weeks. Now, if they're on it for more than 3 weeks, and if the equivalent dose is more than 20 milligrams of prednisone for more than 3 weeks, well, yeah, that's a problem. They will be suppressed. And in those patients, we would cut them back to a replacement dose, get them on a hydrocortisone, recheck a cortisol level in the morning before they take their morning dose of hydrocortisone.
Thank you. Dr. Wiam, you have a question? If not,
Yes, I have a question to address
Yeah.
to Dr. Ahmed Hassoun. The question is, if a healthy patient with no hypertension had adrenal lesion of less than 1 centimeter only, what is the workup and the follow-up according to the Endocrine Society guidelines?
And I think, as we said, the definition was 1 centimeter and above. I don't know if you can hear me. Yes, okay. But I think smaller things, now we are seeing much more with the advances in technology. So probably things are changing, and maybe Professor Young would probably have more update on this. But basically, is a small one like this, I would look into the clinical features first of the patient, if he has any features of, let's say, Cushing or, adrenal secreting hormones. And if it is a small one, at least I look into that. And if that's there, then I would probably go further steps to investigate. Otherwise, I would not investigate. I don't know about Bill, what you think about that.
How about the follow-up? The follow-up, was it, you'll do it every year? As well?
Yes, if I didn't do it for sure, I'm going to follow up this patient. I would do probably 6 months follow-up with an imaging.
Dr. Bill?
Yeah, so I agree with Ahmed. In that 2007 review, I used 1 centimeter because basically you want to be sure you actually have a true adrenal nodule, and it's not just some thickening of the adrenal limb. But the resolution of CT imaging has improved, right, with every generation of scanner. So yeah, now we're seeing clearly it's a nodule. It's 9 millimeters, it's 8 millimeters, 7 millimeters. So really, as long as you're certain it's a nodule, yeah, it's a nodule. But I don't think we should be doing the whole workup that Ahmed shared with us today if we're just talking about some thickening of an adrenal limb. So it's just a matter of making that distinction so that you as the endocrinologist are comfortable that you actually are working up a patient who has an adrenal nodule.
Thank you. Hussein, you had a question? You're
Dr. Al-Maliki, we have a few questions as well. The role of measuring ADH in the diagnosis of DI, as well as the use of medications such as non-steroidal anti-inflammatory drugs like indomethacin for the treatment of nephrogenic DI.
Regarding the first question, the ADH or vasopressin, it has no role in the routine practice. As you see from my presentation, it has several limitations. As the stability is almost for 24 to 48 hours, and the turnaround time is around from the 7 to 10 days. In addition to that, the reliable assay for the vasopressin is not frequently available. So it is not part of our routine practice. And regarding the other question, non-steroidal anti-inflammatory drug, as you know, this is it's work based on the fact it inhibits prostaglandin synthesis in the kidney, which is antagonize the effect of the antidiuretic hormone. So once we give it, it will help to increase the concentration of the antidiuretic hormone with the net effect on the urine output from 25 to 50%. But you have to remember that not all non-steroidal are equally effective. Indomethacin, it appears to have greater effect as compared to others.
Thank you, Dr. Musa.
I have a question for Dr. Salim. The question is, a patient had history of craniopharyngioma surgery, and as an adult, he came to you for symptoms of growth hormone deficiency. When you treat, would you worry about any recurrence or any issues related to the previous craniopharyngioma?
If the tumor was resected completely or resected partially and treated with radiation, then there is no concern. There is no risk of increase. We had a couple of patients in our series and in other patients. The concern was one in our patient was actually not craniopharyngioma. One patient was with macroprolactinoma, and he was treated medically only, and there was a rise in the prolactin level on growth hormone. However, when we examined, he came from a different institution, but we went back and examined all his prolactin levels. We actually found the direction was arising progressively before. We had to stop him on safety basis anyway. But I think if the patients are resected completely or resected totally or treated for radiation for any tumors, there is no concern about that.
Would you do serial MRIs?
I think the standard of care will continue as before. There's not been a specific recommendation for that.
Hussein?
Yeah, I have a few questions for Professor Young. One relates to the regimen that you mentioned. Does it really relate to the underlying etiology of the HPA axis suppression? Say, for example, endogenous versus exogenous, Cushing's syndrome versus treatment for rheumatoid arthritis with prednisone and then tapering off the prednisone. Does it really matter, or that's it? HPA axis suppression is treated the same way?
In my view, HPA axis suppression is HPA axis suppression, whether it's from cortisol from the adrenals or whether it's prednisone, dexamethasone, or some other glucocorticoid given by a physician. They're both feeding back on the hypothalamus and pituitary and suppressing production and secretion of CRH, production and secretion of ACTH.
And a follow-up question on that was, you said that if the patient can't tolerate the withdrawal completely, they could stay forever on hydrocortisone, let's say 10, 15 milligram. Are there any consequences for that behavior?
Yeah, so first let me make it clear, that's not my preference as a physician. My preference is we get them off of exogenous glucocorticoids. The reason I made that point is that, at least in the US, many patients put this responsibility of getting them off glucocorticoids on me as the clinician. And I say, look, you're the one that needs to put up with glucocorticoid withdrawal symptoms. If you can't, that's okay. Stay on 15 of hydrocortisone or 15 and 5. If they ask me if I think that's wise, I'd say no. That's not wise. That's not what I would do if I was on steroids. I'd put up with the glucocorticoid withdrawal symptoms. So, to answer the question, is 15 milligrams a day harmful? I doubt it. It's a fairly low dose. If it's a single dose in the morning. As you know, we replace our patients without adrenal glands when we think they do pretty well on 15 and 5 or 15 and 10. So I don't think we're hurting these people by keeping them on 15 milligrams every morning. It just wouldn't be my preference.
Thank you.
I have a question for Ahmed. If you have a patient who came to you with adrenal incidentilloma and the house field units the attenuation is very low, but there was no washout done because of the fear of kidney issues to this patient, would you follow only based on the attenuation without the washout? Any discordant, results usually between those two?
Not really, actually. Bill Young is expert on this, and anyone who has a Hans field very low, like less than 10, is almost always a benign lesion. And now what to do about it is depend on the case, but it's most likely this is a very benign consideration. So you don't want to do it, the washout.
Thank you. Sam?
It will not add to you more.
Dr. Al-Maliki, a question about pregnancy in a patient with DI on treatment. How should we adjust the dosages?
Usually the Dysmorphism is safe during pregnancy, and we continue in the same pattern, but at the end of the pregnancy, as the pregnancy is progressed, we have some resistance, so we might need to adjust the dose. There is no uniform, there is special steps we have to follow, but we adjust those as based the patient response. So of course, with the progression of pregnancy, we need to increase the dose, but it should be based on the patient intake and output.
Thank you. A follow-up question about also SIADH following DI, following brain surgery. How do you make that diagnosis?
Usually, the sodium abnormality after the pituitary surgery, it can take several forms. Either in one study, around 5% they might present only with hyponatremia. So it's a part of the SIDH, or it can be part of the triphasic phase. This condition should be suspected when the patients start to have hyponatremia or retain fluid with the water balance in some study up to more than 2 liters.
Thank you.
Question to Salim. Salim, the question is, if you want to start growth hormone in an adult and you think the patient is qualified to do so, would you screen for any malignancies before you do that at all, or you don't? You are muted, Salim.
Yeah, I think you go by your good clinical practice. If there are any features, but you're not, you have to look for them before as part of good clinical practice. But there is no need to take a patient and actually do all scans and endoscopies and so on for them. There's no indication for that. You only go by good clinical practice, and on all the studies that were published, the patients had a full physical examination and basic investigation only. They did not look for any tumor markers or any other examinations.
Hussein?
One of the attendees, Professor Young, is asking that after you have confirmed that cortisol is above 10 following the withholding of the pill the day before, that some advocate now doing the ACTH stim test. I know that you are not fond of that, but what do you say for those who recommend that?
Right. So, and that actually was what was commented on in that commentary that was published with our article in Clinical Endocrinology. And their comment was some clinicians may feel better doing a cort stim once the serum cortisol is above 10 micrograms per deciliter. If somebody wants to do it, I think that's fine. I don't do it. We don't get into any difficulty with the patients. They feel fine. Their axis is recovered. Now, I certainly understand those clinicians who have been relying on concentropin stimulation tests for many years, and if they went to this new approach, they may be a little uncomfortable. And to make them more comfortable to do a cort stim, sure. What is interesting though, and as I think all you know, concentropin is not available in every country. There are countries that don't have access to concentropin. So in response to this publication of ours, I've gotten quite a bit of feedback from endocrinologists in those countries that don't have access to concentropin. They said, finally, we have a way to get our patients off steroids and monitor them. And yeah, this makes sense. So it really comes down to clinician preference, I think.
Excellent. Thank you very much.
Dr. Ahmed, a kind of the same question in a different way. You have an excellent washout, more than 60, but you have high attenuation, more than 20. What do you do?
This could be goes, as we discussed earlier, with the lipid poor adenoma, because the washout is significant, more than 60%. So this goes again with a benign lesion.
Even though the attenuation has a high, yeah.
Yeah, because of, as I mentioned earlier, because this lipid poor will have a higher, even unenhanced, more than 10. And these are the cases that really the washout is really necessary in these cases.
Okay. Sam?
Yes, Dr. Musa, we have questions about, do we need to repeat the water deprivation test in patients with DI in whom the first water deprivation test was questionable, or that's it? Are there situations where you repeat it?
Water deprivation test, of course, we will do it if you want to subclassify it to determine which type. Is it central, nephrogenic, or if you're in doubt, this is primary polydipsia. But in case of there is central and there you could not find any cause and you confirm central DI, I don't think that we need to repeat it. I will repeat it if I am still in doubt. Is this partial central DI or primary polydipsia? In this situation, I might repeat.
What about idiopathic DI?
Idiopathic, that's mean this patient has confirmed DI. So I have to look for the cause. And as you know, this represents the most common, up to 50%. And the autoimmune process accounts for majority of them. So I have to look for the cause here, rather than the confirmation of the diagnosis.
Thank you. I recently saw a patient who has multiple sclerosis and DI. Is there an association?
It could be. I have seen a few cases, 2 in my clinic. They have the DI. I think because this is both of them autoimmune process, but as a syndrome, I am not aware about anything like this.
Thank you.
Same thing to Dr. Musa. There's a question about the normal MRI with the bright spot seen very nicely in those cases. Would you rule out completely central DI or still do some workup?
Central DI, the MRI will help to to confirm the diagnosis, to look for the underlying cause. But as you know, it is not specific, not sensitive. As you know, the around 20% of normal population, they have absent bright spot. Even those patients with confirmed, in one study, confirmed central DI, around one third of them, they have bright spot still present, especially at the early stage. So absent or present, it doesn't exclude or confirm diagnosis 100%.
Thank you.
We have a general question for Professor Young about interference of cortisol measurement by prednisolone or dexamethasone.
Yeah, so that's very assay dependent. For example, the assay we used, which was a competitive protein binding assay about 15 years ago, had a 33% cross-reactivity with prednisone and prednisolone. So it did cause problems for us. Since then, we've switched to tandem mass spec assay, which basically has zero cross-reactivity with synthetic glucocorticoids. So, but this is important, I think, for all endocrinologists to know with their lab that they use. What is the degree of cross-reactivity with exogenous glucocorticoids? Usually it's never like 100%, but it could be as much as 33%, which certainly could impact if patients on 20 or 30 milligrams of prednisone, for example. You could have a very detectable, what appears to be, detectable cortisol, but it's just cross-reactivity.
Thank you. A follow-up question is about the use of nasal sprays that contain steroids and injections of glucocorticoids for back pain, for intra-articular and things like that. Would these pose a risk of HPA axis suppression?
Yeah, so a glucocorticoid is a glucocorticoid applied anywhere in the body, on the skin, in the nose, in the lungs, in a joint. They're all absorbed, right? They're all absorbed. And it just depends on the dosage used, that person's degree of absorption of the glucocorticoid. A very common diagnosis, referral diagnosis in our Pituitary Adrenal Clinic in Rochester is low cortisol. And I teach our endocrine fellows, 95% of these will be exogenous glucocorticoids. And that should be your first question. Where did they get a shot into a hip 2 months ago? The effect of a joint injection can last for up to 3 months. And it suppresses the HPA axis and cortisol is low. The duration is much shorter if it's intramuscular or sub-Q or inhaled or oral. But yeah, it is the most common cause no matter how the glucocorticoid is administered.
Thank you.
Dr. Salim, back to you. Do you always routinely do the quality of life questionnaire before starting growth hormone, and is it reliable?
The Quality of life questionnaire, which is actually accepted currently by all endocrinologists, are the AGDA, Adult Growth Hormone Quality of Life. It's available in English and many other languages. I have a version in Arabic that has been being tested, and but I've seen using my own version. Actually, I've seen it improving. If you think, for example, in practice in the United Kingdom, it is important to do an AGDA score before, not important, it's required to do an AGDA score before, and you need to repeat that in 6 months. If there's no improvement in the AGDA score after 6 months, one should consider stopping the growth hormone treatment. A copy is available to anybody who wants to use it.
Is it patent, Salim?
No, not patent. Free for you.
Okay, just a question again. A meningioma case, and you want to start a growth hormone, and it's a small one, been followed up for years and no growth. Would you be concerned giving growth hormone?
I think that's a very individual case, whereas you need to talk to the neurosurgeon, to the neuroendocrinologist, if you have, who's been looking after the patient. Is there a need for growth hormone treatment in this patient? Is it actually the last point of care that you want to give? I have seen patients who actually need so many other things, much more important than growth hormone treatment. And I actually spoken to the father. I said, you've been coming to this clinic asking for growth hormone for so long. There are so many other things that I should need to attend to in these patients rather than asking for growth hormone. So I think I have to be very careful in these patients.
Thank
you. The questions never end for Professor Young. So we have few questions. One, you mentioned what Dr. Hassoun said about the less than 1 centimeter. If it's an adrenal thickening and not a clear nodule, then that is not an incidentalloma. What is it then? And how do you follow these abnormalities? Do you follow or you don't follow?
Well, for me, adrenal thick, if I see a slightly thick adrenal and it was incidentally discovered and the patient has no signs or symptoms of any endocrine disorder, I don't work it up. Adrenal thickening is incredibly common. All you have to do is start looking at every CT your patient has. I don't work those cases up.
Okay, good. And we have a question that is just, I guess, semantics perhaps. If someone had a cortisol secreting adrenal adenoma and you resect it, and after that they develop, low cortisol, do you classify that as primary or secondary? I vote for secondary. What do you call it?
Yeah. I'm with you. Yeah, because it's secondary and it's temporary, and I make it real clear in my problem title, that so no other clinicians get confused. I frequently use the word temporary. The last thing we want is for these patients to get labeled with permanent adrenal insufficiency. So I say temporary suppression of HPA axis from cortisol secreting adrenal adenoma resected on such and such date. And I'll do the same thing for exogenous use of glucocorticoids. I'll say temporary suppression of HPA axis iatrogenic due to prednisone usage. Because what happens, and it happens all the time in the US, patients get labeled with Addison's disease. They never had Addison's disease, but they carry that diagnosis. And yet you kind of dig through all the records and you eventually find out, no, they were given prednisone for a year. And that was what caused their problem.
Interesting. Thank you.
Another question to Dr. Young, actually, same question almost. A patient who had autonomous cortisol secretion and the patient is bossed up. Do you check for cortisol next day or after? And is the 10 the cutoff also?
Great question. So for patients with primary aldosteronism, we check their aldosterone level the day after surgery. We want to be sure that we've actually cured them and we did the right thing. For patients with pituitary dependent Cushing's, we check cortisol the day after surgery. to be sure that we cured them with our pituitary operation. However, for patients with a cortisol secreting adrenal adenoma, we do not routinely check cortisol the day after surgery. Usually there's no question about what the diagnosis is and the completeness of the surgery. So in those patients, we give them a steroid prep for surgery, and the morning after surgery, they're on glucocorticoids. And surgery in Rochester, they're just in the hospital overnight, so they're going home the morning of day 2, and they already have their prescription for prednisone to go home on. So the first cortisol check I do in these patients typically is only once they're on hydrocortisone, single dose in the morning.
So everybody gets replacement.
Yep.
Hussein?
For Dr. Musa, we have a question about in patients who develop DI after head trauma and they have a normal pituitary MRI, is there any chance for remission?
Post-head trauma DI account for about 4 to 26% of the cases. Unfortunately, it is undiagnosed in our practice. And most of the time it is transient and to resolve within 1 week. However, the minority of patients, they might have permanent, especially in group, they have severe head trauma or require long-standing ICU admission, or they have significant damage to the hypothalamus.
Thank you.
But most of the time it is transient and it will resolve.
Thank you.
To Musa, also, there's a question about your thought on hypertonic stimulated copeptin testing in real-life practice.
The copeptin, the literature is and the current data is promising. It is a good test, and the patient with a permanent DI is a good test, and it has a lot of advantage in terms of stability and the turnaround time within a few hours, and the accuracy of the assay. But unfortunately, it is not available. I did this in only 2 patients as a send-out test. So if it is available, of course, it will help us, and it will make the story short in terms of the diagnosis. And as you can see from my presentation, as the baseline without prior testing, if it is more than 30 or more than, in some study, more than 21, this is the confirmed diagnosis of the nephrogenic DI. But if it is less than 2.5, this is going with the central DI. However, if it is in between, you have to do the dehydration test, and the ability to differentiate between primary polydipsia and central DI is very high in this situation. So if it is available, of course, it will be a good test. But in the post-op copeptin measurement, it is not recommended yet for several reasons. Availability, as I said. The other issue regarding the optimal time for testing. Some study they found if you do it within 12 hours, you will have good results. But with time, the sensitivity, or the accuracy will be less.
So this is using hypertonic saline for a copeptin.
Copeptin, there are 2 methods. Either you give start dehydration, this one method. Other one is you give hypertonic saline. Both of them validated, and they found the hypertonic has more superiorities, more diagnostic accuracy than the water deprivation test.
Thank you. We have 5 minutes more.
Yeah, Dr. Young, do you prefer prednisone over hydrocortisone for patients with permanent AI who need glucocorticoids?
Actually, no. If a patient has permanent adrenal insufficiency, we've shown that prednisone has marked inter-individual variation in biologic activity. In other words, we've seen iatrogenic Cushing syndrome in patients treated with just 5 milligrams of prednisone every morning. So if possible, I personally like to use hydrocortisone. There's less inter-individual variation in terms of biologic availability, and the correct dose is the lowest dose that the patient feels well on. There is no lab test that guides you. This is not like giving thyroid hormone and measuring TSH. So it's the lowest dose the patient feels well on, and the highest dose would be 20 and 10. I mean, that used to be the old standard dose, but these days we're trying to get the patients the lowest dose that they feel well on. And it might be 15 and 5, might be 10 and 5. Usually we wouldn't go below 10 and 5, or it might be 15 and 10.
Do you like the triphasic hydrocortisone?
Oh, I wish I had it. We don't have access to it yet. I have some European patients that are on it, and it seems to work reasonably well. But I have no personal experience beyond that.
Thank you.
Question to Ahmed Hassoun. Is there any role for a PET scan in looking at adrenal incidentinomas?
For sure, there are some, as we mentioned earlier, comparing the people who have less likely to be malignant and benign, they have, PET scan. If they did for them, they will see there is more avidity for malignancy. So it has some role, but it's not like the main thing to start with. You can use it in some cases that you are not sure about it. You need some more evidence to help you, or in cancer cases, it would be something to help you. Yes, it has a role. It's not in the immediate, workup of the patient.
Thank you. Hussein? I have a question to Dr. Salim. Athletes who use growth hormone, we see it a lot, unfortunately, in this part of the world, and they use it for a long time. After stopping it, would they have the symptoms of growth hormone deficiency? Do you do anything specific, or you do the same workup for them?
I think the indications of the legal indications for growth hormone are very clear. Growth hormone deficiency in children, growth hormone deficiency in adults, and AIDS-associated weight loss and all the deficiency of muscles, and so the wasting that happens with the AIDS syndrome. And experts in AIDS, they say they are not seeing this more now. All other uses for growth hormone are illegal. If somebody comes to me to the clinic and mention that actually they want this, I say, I'm sorry, I don't give that. And I'll tell them it's illegal and there's no benefit from it. The problem actually that they get from the gym trainers growth hormone with other things that work on them, which is they give them high dose of testosterone. Also, the doses they use, although there's nothing in the medical literature about that in full detail because it's all black market, they give higher doses. But I wouldn't actually, I wouldn't treat them for that because it's not something that actually suppressible. So I won't treat them for that. I will educate them and tell them stop using it. It's of no value, more side effects than benefits.
Hussein, I think we have time for another question.
I think I'm done with the questions here for Professor Young and Dr. Al-Maliki. Thank you very much for answering all these questions.
I have one last question here, and we have 1 minute for it. It's for Dr. Young. The question is about the old way of tapering the steroids, giving it alternate days. You did not mention that in your practice.
Yeah, that's a good point. We really haven't used that. That falls more into the realm of rheumatology. They tend to do that because they're trying to get patients on a lower dose and they still want to treat their rheumatologic disorder. But when we're trying to taper for recovery of the HPA axis, we find a short-acting glucocorticoid every morning works very well. Now, could there be an alternate way of doing it every other day? Absolutely. What I've shared with you today is one approach. I'm sure there are another 15 approaches that could be just as good, but I know this one works, and that's what I wanted to share today.
Thank you. Thank you very much. At the end, I'd like to thank all of you. I'd like to thank Dr. William Young from Rochester, Minnesota, Dr. Ahmed Hassoun from Dubai, Dr. Salim Bishaya from Abu Dhabi, and Dr. Musa from Riyadh, and Dr. Hussein Saadi from Abu Dhabi for co-chairing. It was a very nice session. We had lots of time for questions, which is, I think, most people enjoyed it. I thank you. Inshallah, we'll see you next year.
Good evening, everyone. I'm chairing this session, Dr. Mohammed Lemki from Oman, and it's a pleasure to introduce Dr. William Young from the States. He's had a wealth of experience for both the adrenal and pituitary disease, working at Mayo Clinic, Rochester. He does not need much introduction, but today he will address adrenal cases, challenging cases for us to learn, and hopefully it will be a great learning experience. And you're all, after that, kindly address your questions in order to raise your level of clinical practice and understanding of the situation. Professor William Young, kindly start.
Thank you, Dr. Lemke. It's a pleasure to see you again. It's an honor to be invited to participate in your annual Congress. I'm just going to pull up my slides here. So I've been asked to address challenging adrenal cases. Lots of adrenal situations are challenging. I've picked two, and I'll share them with you today. With regard to this presentation, no relevant financial relationships to disclose, and I'll not be discussing off-label drug usage. The first case is a 46-year-old man with a 15-year history of hypertension, which accelerated 10 years ago, and now he has poorly controlled hypertension. He's on 3 antihypertensive drugs, a calcium channel blocker, a beta blocker, and an ACE inhibitor. But he's also taking 40 milligrams of potassium per day, and he's not on a diuretic. So that's a huge clue right there. Beyond his hypertension and his hypokalemia, he's quite healthy. BMI is 29.2. He has no signs or symptoms of overt Cushing syndrome. He does have diabetes mellitus. He does not have diabetes mellitus or osteoporosis. He has 2 first-degree relatives who have been diagnosed with hypertension. So he probably has polygenic hypertension in the background, but with something superimposed on top of it. So here is initial electrolyte panel. Serum potassium is 3.3, and that's despite taking potassium supplement daily. His plasma aldosterone concentration measured in the morning is 26, and clearly it's inappropriate for the prevailing renin level of less than 0.6. I personally don't use an aldosterone to renin ratio. I just want to see the aldosterone above 10 nanogram per DL and the plasma renin activity less than 1. That's a positive case detection test. Because of his spontaneous hypokalemia, technically we didn't need to do confirmatory testing in his case. I got this 24-hour urine on the first day of his evaluation. His aldosterone in the urine was 28 micrograms. And you can see he was on a high sodium diet every day. I didn't salt load him. That's just what he's eating. And anything over 200 is a high sodium diet. And in that setting, if you're normal, the urinary aldosterone should be less than 12. And he was 28. So that absolutely confirms the diagnosis. So here's the adrenal CT. It's an axial image, unenhanced. He's got a 4.2 centimeter left adrenal mass that has an indeterminate attenuation at 15.6 Hounsfield units. Interestingly, the right adrenal gland appeared atrophic. You can just see part of the right adrenal gland here. You'll have to take my word for it. It also appeared atrophic on the other images. His morning cortisol was normal at 12 micrograms per DL. ACTH was undetectable, so that's interesting. DHA sulfate was low at 38 microgram per DL, normal being 48 to 244. Most common reason to measure DHA sulfate is in the workup of hirsutism in women. However, I think the best use of DHA sulfate is how I used it in this case. DHEA is made by men and women, and it's dependent on secretion of ACTH from the pituitary. When DHEA sulfate, which has a 16-hour half-life, it's very stable. When it's low, it suggests there's been chronic suppression of ACTH for whatever reason. So it's like my adrenal glycosylated hemoglobin, and I use it as a screening test for subclinical Cushing syndrome. If a patient has glucocorticoid secretory autonomy from an adrenal nodule, then you can see DHA sulfate levels slowly drop. So his is low. I think that's clinically important. I went straight to an 8 milligram overnight dexamethasone suppression test. I didn't want to deal with any false positives related to a 1 milligram overnight dex suppression test. Normal suppression is basically undetectable cortisol with this test. He's 5.9. 8 milligrams of dexamethasone is about 16 times more glucocorticoid than a person makes in a day. There's no reason to have detectable cortisol the next day. So did we do adrenal vein sampling? No. Here's the Endocrine Society diagnosis and treatment algorithm that we wrote for primary aldosteronism. I didn't put the citation here, but it's published in Journal of Clinical Endocrinology and Metabolism. And in this more recent guideline, we provided a bypass for adrenal vein sampling. And that was in a patient who has an adrenal CT. If the patient is young, less than 35 years of age, with the marked primary aldo, that means spontaneous hypokalemia, plasma aldo over 30 nanograms per DL, and clear-cut unilateral adrenal adenoma, you can consider going straight to surgery. Because in that setting, you shouldn't be fooled by a non-functioning cortical adenoma because of the person's young age. And the larger the adenoma, the more severe primary aldo. So we provided that adrenal vein sampling bypass in that version of the guidelines. That's not what we're talking about with this case here, though. What we're talking about is a unilateral adrenal macroadenoma in a patient with primary aldo and subclinical Cushing's. And what I'm suggesting today is in this setting, it's also a reason to bypass adrenal vein sampling. So the patient went to laparoscopic left adrenalectomy, perioperative glucocorticoid coverage. The left adrenal weighed 36.4 grams, so it was large. Normal adrenal weight's 4 to 5 grams. And there was this 3.5 centimeter yellow cortical adenoma shown by the arrow on the bottom right. We measured the aldosterone level the day after surgery to confirm we accomplished what we hoped to, and aldosterone should be low. In this case, it was less than 4 nanogram per DL. We stopped potassium supplementation and his ACE inhibitor the day after surgery. We advised him to monitor blood pressure daily and have blood pressure meds adjusted as needed for high normal blood pressure for that first month after surgery. That first month, we don't want our patients hypotensive. We don't want them pre-renal. He went home on 20 milligrams of hydrocortisone every morning with instructions to decrease the dose to 15 milligrams in 2 weeks. So he had weekly blood potassium checks. There's a small subset of patients who will develop clinically important hyperkalemia after surgery. And if potassium's over 5.2 milliequivalents per liter, they need to go on fludrocortisone for a couple of weeks. In his case, potassium remained normal. Serum creatinine remained normal. And he had good blood pressure control on lower dosages of amlodipine and labetalol. So that's fantastic. His morning serum cortisol was obtained before his morning dose of hydrocortisone 6 weeks later, and it was greater than 10 micrograms per deciliter, telling us that his hypothalamus was making CRH, his pituitary is making ACTH, and his adrenal was making cortisol. So at that point, we stopped hydrocortisone coverage. So key points with regard to this case. First, when a patient with PA has a large adrenal adenoma, greater than a centimeter and a half, and clinicians should screen for cortisol co-secretion with baseline DHA sulfate and overnight dex suppression. That could be 1 or 2 milligrams. But again, I don't like dealing with false positives. So in this setting, with an adrenal mass, I use 8 milligrams. You can use as much as you want. What you want to know is how much true autonomy is there. So the 8 milligram overnight dex has a role to absolutely confirm glucocorticoid secretory autonomy. A normal serum cortisol concentration following 8 milligram dex would be 0, undetectable. If autonomous cortisol co-secretion is present in a patient with PA who has unilateral adrenal macroadenoma, I don't think we need to do adrenal vein sampling because this is co-secreting aldo and cortisol. Now, could it be a patient with bilateral hyperplasia and a unilateral cortisol secreting adenoma? Sure, but we don't have a good long-term medical treatment option for those patients. And whereas we have a great medical treatment option for patients with primary aldo, and that's a mineralocorticoid receptor antagonist, spironolactone or plinabulin. We don't have a good treatment option for cortisol. So patients with aldosterone cortisol secreting adenoma should have perioperative stress glucocorticoid coverage, go home on a morning dose of hydrocortisone until the HPA axis recovers. So let's move on to case 2. It's a 71-year-old man referred for evaluation of incidentally discovered right adrenal mass. CT scan was obtained 5 years previously to evaluate left lower quadrant abdominal pain, and at that time it incidentally detected a 1.8 centimeter right adrenal mass. Subsequent CT scans showed that this mass was enlarging by an average of 4 millimeters per year. And when I saw the patient, his tumor measured 3.8 by 3.3 cm. So that's the initial CT scan. Here it is 2 years later. You can see it's slowly enlarging 4 years later and 5 years later. Hypertension, 5 years duration, was effectively treated with a calcium channel blocker, ARB, and a beta blocker. Diabetes of 2 years duration was treated with metformin and rosiglitazone. He had no signs of adrenal cortical or medullary dysfunction. He had a history of prostate cancer, treated with radiation therapy 3 years previously. BMI was normal. Blood pressure when I saw him was controlled on treatment. Sodium normal, potassium mildly elevated, creatinine normal, PSA was undetectable. Remember, he had that history of prostate cancer. Aldosterone was 8, plasma reactivity was high at 14. I get lots of email questions about this scenario. This is what renin should be. This is not a renin secreting tumor. Renin should be high if you're treating your patient with a ACE inhibitor or ARB. So we excluded primary aldo. Morning serum cortisol was 17, afternoon 7.6. DHA sulfate was not low in this case. It was normal, 105, and the 24-hour urine cortisol was normal. Now, for some reason, I did not do a DEX suppression in this patient. And as I note here, I think I have a good reason for that. It was based on the imaging phenotype of this adrenal mass. The unenhanced CT attenuation was 39.5. Now, most of you in your imaging system at your hospital can do what I did here. You draw a region of interest around the non-cystic component of an adrenal mass, and it'll give you the unenhanced CT attenuation, 39.5. So that's lipid poor, and that is suspicious. So I screened for pheochromocytoma, and it was diagnostic. Plasma normet more than 9-fold elevated. 24-hour urine norepinephrine more than 3-fold elevated. Norepi in the urine more than 5-fold elevated. So these levels are diagnostic of pheochromocytoma. He's not taking any medication that would cause this degree of false positive testing. So to prep for surgery, I added a non-selective alpha blocker, phenoxybenzamine. I stopped his losartan, but I continued on his beta blocker and his calcium channel blocker. They're both helpful. I titrated the phenoxybenzamine for low normal systolic blood pressure. At laparoscopic red adrenalectomy, the adrenal gland weighed 19.8 grams, and the Pheo measured 2.5 centimeter in maximum dimension. Stopped the phenoxybenzamine the day after surgery, and he was dismissed from the hospital that day. 5 days after surgery, blood glucose was normal without pharmacologic treatment. And we warned the patient about this because when you remove a contrarregulatory hormone like catechols, you may not need medical management for diabetes. And blood pressure was low, was normal on low dose beta blocker at that point. A year later, plasma fractionated were normal, A1C was normal with no medical therapy, and blood pressure continues to be well controlled on monotherapy. 14 years after surgery, the patient continued to do well with no evidence of recurrent Pheo or diabetes. So key points. Due to the widespread use of computed abdominal imaging, at least at Mayo Clinic, 60% of our adrenal Pheos that go to surgery were discovered by accident on imaging done for other reasons. Here's just a graphic that explains that relationship. So this was published in 2019, and we're looking at 4 different series of patients on the x-axis, starting with our very first patient in 1926. Up to 1970, we had 138 patients who went to surgery. The next cohort, 106, next cohort, 140, and the most recent cohort, and the focus of this publication, 271. Percent of patients on the y-axis. And solid bars are those patients presenting with the classic presentation with paroxysms or hypertension. So you can see in the old days, 84% of all patients presented with that classic presentation with spells and paroxysms. But look at 95 to 2004, only half. And now only a quarter present like that. What about those that are discovered by accident? Incidentally discovered, that's going to be shown in blue. And you can see it was a rare event in those first 2 series up to 1980. And usually it was on a IVP to look at the kidneys that was discovered, or it was discovered by accident during surgery for some other reason, like cholecystectomy. But with the spreading availability of cross-sectional imaging, the proportion went up to 31% in this series, and now 61%. And those that were discovered as a presentation of an abdominal mass, that's an old presentation. We just don't see that anymore. And those found because of family testing, genetic testing, that's slowly increasing. 12% in this most recent series. I think when this is looked at again in 10, 15 years, that number is going to be much higher. So lipid poor adrenal mass should be considered pheochromocytoma until proven otherwise. That's a key pearl. Although patients may not have the classic paroxysm associated with catechol hypersecretion, Pheo can result in sustained hypertension and be responsible for diabetes, as it was in this patient. Although all Pheos have malignant potential, they tend to grow really slow, about 3 to 5 millimeters in diameter per year. I'll show you a couple examples. This patient's going to develop a pheochromocytoma in that left adrenal gland. A year later, this is patients getting scans for other reasons. You can see the medial portion of that adrenal is expanded. And 3 years later, there's a definite vascular nodule. And 4.5 years later, it's clearly a vascular adrenal tumor, and it is a pheochromocytoma. Here you can see that baby pheochromocytoma. It's that vascular tiny nodule seen right there. A year later, a little bigger, 2 years later, now a definite vascular nodule. 3 years later, the radiologist notices it and brings it to clinical attention. Now, these are the serial images in the patient I just shared with you today. And you can see the slow growing lipid poor adrenal mass. As Pheos enlarge, they can get these cystic infarcted areas within them. So that was also diagnostic of Pheo in this particular case. Approximately 25% of patients with Pheo have diabetes mellitus, and it resolves in the majority of them after tumor resection. Well, those were the 2 challenging adrenal cases I picked for discussion today. I appreciate your attention, and I'll look forward to any questions you may have during our discussion period. Thank you.
So I'll introduce the next speaker, that is Dr. Khalid. He's from the United Arab Emirates, and he's going to talk to us about update of the acromegaly, of course, the pituitary tumor. He's working both at the Tawam and has been an active member of ACE Gulf chapter. So Dr. Khalid, the floor is yours.
Thank you, Dr. Lamki, for the introduction. Excellent. I have no disclosure for this presentation. And the main objectives actually is to review the literature and present relevant papers over the last 2 years. And I have grouped them into 4 sections. First, we'll cover epidemiology and clinical presentation. Then we'll move to some rare or uncommon comorbidities that are associated with acromegaly, and we'll focus on them. Those are the emerging comorbidities, and we'll focus on some papers discussing management. And lastly, we'll cover acromegaly and COVID. So to start with, I'll present this meta-analysis of 17 studies evaluating the epidemiology of acromegaly. And the prevalence, mean prevalence from these studies is around 59 cases per million. Most of these cases or studies were done in Europe or North America, and we had little entry in terms of data from the Gulf until early 2020, where we had 2 publications, one from Saudi Arabia, led by Dr. Al-Maliki, and there was 195 cases of acromegaly over 9 centers. Similarly, we had 75 cases in 6 centers. If you look for the population of Kingdom Saudi Arabia, 35 millions, and also a third of that in our country, then this is a clear underdiagnosis. It's important to diagnose the condition early. The study highlights the reason for that. This is from a Swedish National Patient Registry. They had 603 patients over 12 years period. The mean diagnostic delay was 5.5 years. About a third did not suffer any diagnostic delay, but a quarter of the cases were diagnosed 10 years after the first comorbidity associated with acromegaly. As you would expect, the more the delay in the diagnosis, the negative consequences of the patient with increased comorbidities, but also increasing mortality if the diagnosis is not made earlier. Literature suggests that women with acromegaly are actually diagnosed at a later age compared to men with a lower IGF-1 level, perhaps because of the estrogen effect or not the so apparent somatic features compared to men. But on the good side, they are more likely to achieve a normal IGF-1 at last visit. Here is the age of the patients. Female are 3 years older compared to men at diagnosis, but they tend to have lower IGF-1 level. Patient with acromegaly, they have multiple manifestations. It's a systemic disease with somatic features, but also cardiovascular, metabolic, respiratory, and skeletal complications. In the coming slides, I'll discuss sleep apnea, vertebral fractures, and some malignancies that are associated with acromegaly. We'll start with obstructive sleep apnea. This is a meta-analysis of 24 cross-sectional studies, including 734 patients, and they looked at the prevalence of OSA and AHI in patients who are active versus inactive in terms of disease status, and then they looked at the effect of treatment. Overall, the preference of obstructive sleep apnea varied widely from 20 to 100%. Similar prevalence in patients who have active versus inactive acromegaly in terms of prevalence of obstructive sleep apnea, and also apnea-hypopnea index, except for the severe cases may be less prevalent in inactive disease. The top figure shows that there is no difference in the prevalence in the apnea-hypopnea index, but with treatment, there is some improvement in the apnea-hypopnea index. The issue with this meta-analysis, it included 24 studies, but only 8 which had a good number of patients, heterogeneous population, and limited by no longitudinal follow-up. Better study is the one that's also published in JCM, 27 patients with acromegaly, single center, but prospective design, and they had polysomnography at time 0, then 1 year later, and then 2.5 years later. Majority had macroadenoma and were pre-treated with somatostatin analog, and then later the prevalence, only 1/4 of patients did not have acromegaly related obstructive sleep apnea, but the majority had, with 1/3 having severe obstructive sleep apnea. With the years of follow-up and treatment, then there is a reduction in the rate of obstructive sleep apnea, and almost 80% did not have obstructive sleep apnea at the 2.5 years mark. And this was associated with better disease control in year 1 and year 2.5. Not only that, there was improvement in different sleep-related parameters, including respiratory disturbance index, the oxygen desaturation index, as an example. And the majority of improvement actually occurred very early in the process of treatment. Within 1 year, you get the majority of the benefit, and the IGF-1 level correlated well with a change in sleep apnea, sleep parameters. So this is a common condition, and we need to pay attention for it, screen for it, and evaluate for its improvement. Another comorbidity, which is disturbingly high in patients with acromegaly, is vertebral fracture, reported anywhere from 11% to 87%. And there are multiple risk factors for it. Disease being uncontrolled is one risk factor, but there are something other than the growth hormone and IGF-1 level, which is hypogonadism, diabetes, pre-existing vertebral fracture, and also treatment with radiotherapy. Literature suggested that BMD is not a good test to evaluate those patients because they continue to fracture with normal BMD. Maybe trabecular bone score is better. Sclerostin level was found to be similar in patients with active versus inactive acromegaly and did not predict vertebral fracture. Progression occurred even in those with controlled cases. There was a data suggesting bone active agent can be helpful in preventing vertebral fractures in active acromegaly. And in the subset of patients who were treated with pasireotide, they gained better benefit, and they had a reduction in vertebral fracture more compared to pegviscement treated patients. So there are reasons why a patient had very high vertebral fracture in some studies, why not in that study. And this paper explains some of the differences where they looked at acromegaly from 2 different centers, one from Romania and one from US. And you see in general, there are common comorbidities shared between 2 centers like hypertension, diabetes, and dyslipidemia, but there are some more frequent than other in certain centers. For example, in the center from US, obstructive sleep apnea, vertebral fracture, and colon polyps were more common compared to one from Romania. Romania had more thyroid nodules, and the reason for that is simple in this paper. If you look for it, you will find it. So they were investigating more, and they found the comorbidity. However, the very high rate of vertebral fracture is something that we don't see frequently, actually, and we think that there is something else to it. Another paper from France shed some light on this area, and they looked at 50 patients with acromegaly over 30 years period, single center, with proper evaluation for the presence of vertebral fracture, radiological evaluation, 2 blinded experts in the field, and also a third if there was a question or concern whether this patient had vertebral fracture or not. And they found only 3 out of 50 actually having vertebral fracture. So 6%, so much lower than the reported rates in the previous studies. But what they found is that there is a significant deformities either osteophyte, disc narrowing, grade more than 2, or wedge-shaped vertebrae. And this happened in 86% of the patients, similarly in the thoracic and the lumbar spine. And they quote this, the presence of frank deformity, as possibly the reason for overestimation of vertebral fracture. So this is an important and interesting piece of information from this article, and I think it needs more study to validate it. Thyroid cancer, there is a concern about the increased risk of thyroid cancer in patients with acromegaly. We have 2 studies addressing this over the last 2 years. One of them is a retrospective study from a large academic center in USA, evaluating 221 patients with acromegaly. About half of them underwent ultrasound with evidence of thyroid nodules in 71 patients. 17 had FNA, and 4 of them, they had either suspicious for malignancy results or PTC. 6 underwent surgery, and the prevalence of papillary thyroid cancer in this cohort was 8.5%, which is very similar to the and the authors on this study, they do not recommend routine use of. An even better study is a study that comes from Brazil. It's a prospective single thyroid nodules, all versus the volume of thyroid was larger in patients with acromegaly. The prevalence of thyroid nodules were higher, and about 55% in both groups had indication for fine needle aspiration. None of the cases of acromegaly had thyroid cancer, compared to 2 patients in the other pituitary adenoma group. A second study suggesting no increased risk for thyroid cancer, and perhaps no need for routine ultrasound in those patients. Colorectal polyps is also frequently found in patients with acromegaly, and there is a question whether it is associated with increased risk of malignancy. This is a retrospective study from Japan evaluating 178 patients with acromegaly who underwent colonoscopy versus control. And what they found is that the proportion of patients with acromegaly with polyps were much higher in acromegaly group compared to control. The number and size of polyps were higher in the acromegaly group, but the histology in terms of high-grade adenoma or cancer did not reach statistical significance, although numerically higher. So polyps were common, but there is no statistical difference in terms of colorectal malignancy in this study. In another better designed study, multi-center study with colonoscopy done in 70 patients with acromegaly compared to 128 patients with control. Same finding, increased prevalence of polyps in patients with acromegaly. And this time, both advanced adenoma and colorectal carcinoma were more common in patients with acromegaly. And in the acromegaly group, patients who had polyps, they tend to have insulin resistance more frequently compared to acromegaly group without polyps. Most of the colorectal cancer occurred in the descending colon. So this study clearly suggests increased risk for polyp and colorectal cancer, and perhaps still we continue with colonoscopy screening until we get more data. Another emerging comorbidity not frequently discussed is erectile dysfunction. The study from China reporting erectile dysfunction in about 63 patients with acromegaly. The erectile dysfunction increased significantly with age, but if you see this figure here, about 50% of patients with acromegaly who are young, 20 to 30 years, they had erectile dysfunction. And one of the main difference between the two groups who had erectile dysfunction versus no erectile dysfunction was growth hormone. So growth hormone itself, regardless of other confounding factors, is associated with increased risk for erectile dysfunction. This is not something that's frequently discussed, and I guess this is associated obviously with decreased quality of life in those patients with acromegaly. Now we move from comorbidities to diagnosis. We know that IGF-1 is the screening test, but then we go to OGTT if needed to confirm the diagnosis. OGTT, we expect that growth hormone will decrease with glucose load. However, there is a subset of patients where growth hormone will increase. And there is a study evaluating this paradoxical increase in growth hormone, which occurred in almost 1/4 of the participants from this study, which included 110 patients with acromegaly. Interestingly, those patients were older. They had higher frequency of microadenoma, less likely to be invasive. The IGF-1 is more in terms of level compared to those with no paradoxical rise in growth hormone. And they tend to have hypointense T2 and MRI with good response to therapy with somatostatin analog. So growth OGTT might give you some hint about the characteristics of patients that you will see, especially if they had a paradoxical rise in growth hormone. This is an interesting paper, which I thought will be nice to share with you. Now, obviously, we move to MRI once we suspect acromegaly. I always like to see the MRI. The panel on the picture on the left side shows macroadenoma, clear pituitary is pushed on the left, so a good chance of cure. The picture on the middle shows extension to the paracellular with invasion of the cavernous sinus, so maybe cure is an issue. The third one is one with infracellular extension, which we commonly see in patients with functioning adenoma, but also hypointense in T2, which can be helpful sign to predict response to somatostatin analog. So acromegaly guidelines suggest that surgery is the first line treatment for patients with acromegaly, and then medical therapy if surgery is not available or patient is not candidate for it. Data on surgical outcomes for acromegaly has been consistent in showing that patients with cavernous sinus invasion, higher baseline growth hormone, larger adenoma, three of those are associated with lower remission rate. There is some studies suggesting that younger age and preoperative IGF-1 can be useful as a predictor of remission after surgery. Whether sparsely granulated or densely granulated, it does not seem to help with the prediction of outcome of surgery. Always we send the cases to experienced neurosurgeon, and data is consistent about the experience of the neurosurgeon and the better outcome after surgery. If you look at medical therapy, somatostatin analogs in specific, there are 3 papers worth discussing, predictors of somatostatin analog response. Females, those who are elderly, lower IGF-1 level, T2 hypointensity, and densely granulated adenomas are likely to respond to somatostatin analog. If you look at those parameters and you select the best, perhaps the most consistent predictor is lower IGF-1 elevation. Extended dosing of lanreotide can be useful and helpful in some selected patients previously controlled with injectable somatostatin analog. So this might save some cost, and also on pandemic, this might be a good option. People can extend to 6 weeks, 8 weeks of therapy. Pasireotide has also shown better efficacy, not that much, perhaps 15 to 25% compared to the first generation somatostatin analog, but at the risk of hyperglycemia and diabetes mellitus. Now, another paper is addressing the biliary adverse events associated with somatostatin analogs. We know that somatostatin analogs inhibit cholecystokinin, which is associated with later on with impaired motility and predisposition to cholestasis and sludge. In this patient cohort, 91 patient with acromegaly treated with somatostatin analog, they had pre-treatment ultrasound and then annually. 62% of the cohort had biliary adverse events, mostly cholestasis or gallbladder stones. Again, mostly asymptomatic, 5 only were symptomatic and required surgery. 50% of those occurred within 5 years of treatment. 71% were treated with ursodeoxycholic acid, and the response was equivocal, not that great. Those who responded tend to have lower triglyceride, LDL, BMI, and lower rates of obesity as baseline. The response seems to be more in those with sludge compared to those with established gallbladder stones. Issue with this, it's a retrospective single center, no control arm, and it's unclear what was the reason for starting the ursodeoxycholic acid treatment. We move now to oral octreotide. It was tried on 56 patients controlled with injectable somatostatin analogs for 36 weeks period, and then patients were randomized to octreotide oral tablet versus placebo. And those who went to the oral arm, they maintained normal IGF-1 in 58% of the patients, and about 77 had an growth hormone less than 2.5. Obviously, it's an effective medication, and its side effect profile is similar to the injectable somatostatin analog, so might be useful for some patients. Data from pegviscement. We studied the ACRO study, which is a surveillance study of patients on pegviscement. It's an international study, and data available now for more than 10 years. At start of the program, 88% were uncontrolled. The control rate in the green here, green bars, anywhere between 62 to 80%. Similar side effect profile in terms of liver enzyme elevation, 3%. We see in this latest publication a higher frequency of enlargement of tumor, 7%. Previous literature suggests 3% only, and it's well-tolerated medication. Patients who are uncontrolled on somatostatin analogs, you can shift them, you can first try them on cabergoline. If they are uncontrolled and tumor is a concern, you could try pasireotide. If the blood glucose control is an issue, you could try pegviscement. If both are a concern, then you could use somatostatin analog and pegviscement. If uncontrolled, then you move to surgery or radiotherapy. Combination therapy is also was studied and published recently, and this is a publication from the Melmed group where they looked at patients with somatostatin analog. They were randomized to one of 3 arms, either high-dose somatostatin analog plus weekly pegviscement, or low-dose somatostatin analog and weekly pegviscement, arm B, or arm C, low-dose somatostatin analog and daily pegviscement. The arm that achieved efficacy and also reasonable cost saving is the arm B. So option of low-dose somatostatin analog plus weekly pegviscement can be used for patients. Now, radiotherapy was also an area of active research over the last 2 years. This is a meta-analysis of stereotactic radiosurgery, 20 studies, 1,500 patients with acromegaly. The remission rate Endocrine remission is 43% at 5 years, increased at 10 years to 55. Similarly, endocrine control is much better at 10 years, and the local control, which is tumor control, is 93%. Visual toxicity is 3%, and about quarter developed hypopituitarism. Unfortunately, in this study, they do not mention exactly what's the definition of remission and control in terms of IGF-1 level and growth hormone level. Nonetheless, it's an effective therapy. Now we move to the COVID and acromegaly. There's an international survey of endocrinologists asking their opinion about how COVID affected acromegaly management. Most of them, they reported marked delay in surgical intervention. Also, it was associated with negative impact on the ability to monitor patients with labs, with imaging, or seeing the patient. However, people adapted to this new situation with increasing telephone consultation and also emails. We have recently reviewed the group in the MENA region led by Dr. Salim and the authors here, Musa Zaina, Dr. Asha, and Salim Bishaya. We summarize the effects of COVID in the pituitary gland. And if you're interested, you can see the paper. It's published in the Journal of Diabetes and Endocrine Practice. Basically, what we say that oral, if available, is an option. Need to be careful if you're using paclitaxel, especially that some agents may increase the QTC interval. And the rest, you can look at the publication. The positive side in the COVID, the paper published from Diego Veron group, 75% of patients controlled in 2009 pre-COVID remained under control in the COVID year as well. So control of acromegaly was not an issue in this large center, although the reduction in the clinical visit was noted in 2020, but this was compensated by telephone consultation. I think a look into the future is that machine learning and artificial intelligence will help us in early detection of patient, perhaps also utilizing some data in assessing remission rate. There are more drugs to be studied and perhaps will be soon available. Some of them I have discussed, the oral octreotide, and some I did not. This is antisense therapy. And because of time, I'll leave you with a quick summary. There is a delay in diagnosis of acromegaly, which remains an issue till now. Colonoscopy, but not thyroid ultrasound, is advised. Cavernous sinus invasion is the most important predictor of surgery outcomes. Biliary side effects are common. Stereotactic radiosurgery is effective in achieving endocrine and tumor control. And perhaps we'll see more roles for machine learning and artificial intelligence in diagnosis and remission prediction in acromegaly. And I thank you for your attention.
So thank you to both speakers. Now we'll go into the session of questions and answers. So the first question from Dr. Sajwani to Professor Young. A confirmed Cushing's condition, and basically 24 hours urine cortisol is high, and ACTH was low, normal, with DHE was also normal. Imaging showed the pituitary microadenoma and bilateral adrenal nodules. IPSS was not available. So the question basically, he wants to know what can he do to confirm, since ACTH is low, and the incidental pituitary microadenoma, is it actually the cause of the Cushing's, or it's at the adrenal nodules?
Yeah, this is a tough issue, right? We published a couple years ago a problem we had with our ACTH assay. In other words, it had problems with false positives. And we got into pickles like this one, where it was actually adrenal dependent Cushing's, but the ACTH was mid-normal. And we were confused by that. So one of the first things I do in that setting is I contact the lab, and it's good to do serial dilutions on the ACTH to make sure it's real. Another option is send the ACTH out to a different lab. I didn't quite hear if the DHA sulfate was high or low. That can help too, because DHA sulfate's dependent on ACTH. If DHA sulfate is low, then that would suggest it's an ACTH independent situation. But yeah, you need to get this right to begin with. Usually if it's adrenal dependent, no matter what dose of dexamethasone you give, there should be no drop in urine cortisol or blood cortisol levels. Whereas if it's pituitary dependent, typically you'll get a fairly marked drop in serum cortisol, for example, with an 8 milligram overnight dexamethasone suppression test. So without knowing any more particulars, I guess those are some of my thoughts. I'd be happy to respond to an email if more details were provided.
Your opinion for medical therapy of acromegaly with succession just to avoid surgery and to maintain fertility. What is your opinion for medical therapy? If you're going to avoid surgery and maintain fertility.
Okay, I think the first line treatment for acromegaly should always be the surgery, especially in experienced center. So I won't just select medical therapy just to maintain fertility, because you could completely resect the tumor and preserve the pituitary function in many patients. Also, you could improve the pituitary function after surgery in some patients. For example, patients with acromegaly, about a third of them, they might have hyperprolactinemia, which negatively impact on the fertility as well. So you could cure that if you totally remove that tumor.
Thank you. So basically, Dr. Hatsoun is asking, what is the rate of growth? And will you be able to differentiate between a pheomas, which is benign, versus malignant?
Oh, that's a tough one. So it turns out that all pheos have malignant potential. And that's why in general, we want to take them out when they're small rather than when they're large. The larger the pheo, the more likely it could be malignant and metastatic. And paragangliomas, extraadrenal catecholamine screen tumors, also have an increased risk of being malignant and metastatic. I'm not aware of anyone having data looking at growth rates and of adrenal masses that prove to be pheo and saying whether the long-term outcome was benign or the long-term outcome, the patient had metastatic disease. I'm not aware of any of those data. One would speculate that, a more aggressive pheo that grows faster would be more likely to be malignant and metastatic, but I don't have any data that proves that.
Thank you. There's another question, and that is the use of iodocholesterol for diagnosing pheo. What is your take on?
Right. So iodocholesterol scintigraphy was an old scan used for primary aldosteronism, because iodocholesterol is taken up by the adrenal cortex, and if someone's making a lot of aldosterone, that adrenal can light up. It's no longer available for use in the United States, and we never used it for pheochromocytoma. I suspect the person asking the question meant to ask about meta-iodobenzylguanidine. So I-123 MIBG is taken up by the adrenal medulla in normal people, but it's also taken up even higher and hotter in patients with catecholamine secreting tumors. So the question is, what's the role for that test? It's had a declining role over the years as CT and MR have become better. We can predict based on CT which patients actually have a most likely have a pheochromocytoma, and the sensitivity specificity of biochemical testing has also gotten better over the years. So although I used to order MIBG scans every week, now I might order it 3 times a year. And usually it's to look for metastatic disease. But even for that, gallium-68 dotatate PET-CT has really replaced MIBG looking for metastatic disease. So it's had a declining role over the years in localization.
Okay, there's another question, Professor Young, and that is, do you have cases of indolent pheochromocytoma where the normal urinary metanephrines remain normal, and over a period of time, it starts secreting again and becomes more apparent? This is from Dr. Shada.
Yeah, this is a good question, and that's exactly what happens. So all pheochromocytomas are pre-biochemical when they're small. In other words, the factory is not big enough. Whereas an aldosterone producing tumor can be 4 millimeters, cause the whole syndrome. A 4 millimeter pheo, the factory is not big enough to make enough catechol to be biochemically detectable. So I showed you some of those small pheos. So biochemical tests were normal. And only once a pheo gets to be about 1.5 centimeters in diameter, it might be biochemically detectable. But even then, it may be biochemically silent. So absolutely, if you follow lipid-poor adrenal masses over time and watch them grow and get biochemistry for pheo, not that I'm advocating you do this, they will become biochemically detectable the larger the factory.
There's another case for you, sir. A case in the ICU with severe hypertension and treated with labetalol. And his urinary metanephrines were elevated, but CT scan of the abdomen and neck revealed no masses, either adrenal or otherwise. So the question is, what is your point of view? Is this a false positive result, or he should be followed and reinvestigated again?
Yeah. So there was a nice article in Journal of Clinical Endocrinology Metabolism published earlier this year, and it highlighted something that I've personally been saying for years, and that is we don't have a good biochemical test in the ICU. All the patients in the ICU will have elevated norepinephrine and normetanephrine. They should have elevated levels. They're sick, right? They're stressed. So this article compared ICU patients to bona fide pheo patients, and there was no difference. They have the same levels, their same degree of elevation. So the test in the ICU, if you're worried about pheo, it's not biochemical. It's CT with contrast, abdomen, pelvis. 85% of all catecholamine screen tumors are in the adrenal glands. 95% are between the diaphragm and the pubis. So if I have a negative CT with contrast, abdomen, pelvis, the chance my patient in the ICU has a pheo, very, very low. It's not zero. They still could have a cardiac paraganglioma, for example, but it's very low. So the patient described, it sounds like it'd be very unlikely that that patient actually has a catecholamine screen tumor.
So your second case, there was a question, does it require or warrant to do a genetic testing for your patient? This is a question put forward.
Good question. So we published a review in the New England Journal of Medicine in the summer of 2019, and there's a nice graph in there where it shows, based on the decade of life within which the tumor is discovered, the probability of finding a mutation that predisposed and caused the tumor. So in the first decade of life, for example, 90% of those kids have a germline mutation that caused their tumor. And the second decade of life, it's still high. It's like 80%. But that percentage drops. So I think the patient I presented was 60 or 70 years old. So the likelihood of a pathogenic germline mutation at that age is about 20%. So that's the discussion I have with the patient. In the United States, we need patient consent to do genetic testing. I had that discussion with that patient and he declined. And that happens a fair amount in the US. But yes, I have the discussion of genetic testing with all patients who have pheochromocytoma or paraganglioma, but you need their consent in order to do it.
Dr. Zahrani is asking you if the use of 8 milligrams dexamethasone suppression test can give a false results if the condition is mild to moderate.
So again, the main reason I use the 8 milligram overnight dex suppression is to prove that the patient has adrenal autonomy. And a normal cortisol level after 8 milligrams of dex would be undetectable, be less than 1 microgram per DL. If it's 2, 3, 4, 5 microgram per DL, that's telling me there's some autonomy there. Again, we're assuming that it's an outpatient, not in the intensive care unit and so on. Yeah, then there's autonomy. In the setting of a unilateral adrenal mass, that's telling you that that adrenal mass is autonomously producing that much cortisol. Then it's up to the clinician, assuming the patient doesn't have clinical Cushing's, it's up to the clinician to determine, is that degree of glucocorticoid autonomy important for that patient? It's as if the patient is taking 4 milligrams of prednisone every day, distributed over 24 hours a day. Is that important for that patient? Has it caused hyperglycemia, hyperlipidemia, osteoporosis, hypertension, and so on? The way I share that with the patient, and in general, especially the younger the patient, this problem's not going to go away on its own. It's only going to get worse with time. And if you have access to an expert laparoscopic adrenal surgeon, we're actually quite aggressive with our patients with adrenal-dependent subclinical Cushing's syndrome.
There's another question for you. If there's any risk of doing dexamethasone suppression test in few cases?
Absolutely, and that's why I highlighted it in that second case. I said I didn't do the overnight dex for a reason. And the reason I didn't do it, it was a lipid poor adrenal mass. It enhanced with contrast. It had that little cystic area in it. So it had the imaging phenotype of Pheo. So although we say all patients with adrenal incidentalloma should be screened for subclinical Cushing's, there's a caveat there. And that is assuming they don't have pheochromocytoma. There's a nice article out of the Netherlands published about 6 or 8 years ago in Journal of Clinical Endocrinology Metabolism, where they did a literature review, and they showed that high dose steroids, whether 8 milligram of dex or a steroid injection into a joint, can precipitate a pheochromocytoma crisis. 1 milligram overnight dex has not been documented to cause a pheo crisis.
Question to Dr. Khalid. Last question. What is the outcome of diabetic retinopathy in patients with acromegaly? Dr. Khalid.
You spared the difficult question at the end. I don't have answer. I don't know if this is studied in the literature. No answer here.
Okay, so I'd like to thank both speakers, all the participants, and I think we can close the session now. Thank you, gentlemen.